Dr. Fishman, I think you are muted.
Okay, I'm not me. I'm not okay.
That's okay.
You see my screen?
Yes.
Yes. So, can we wait like 5 minutes from now?
Yeah. I mean, I'll stop sharing. Okay.
Okay.
Then we want me to do? Yeah, I'll stop sharing. That's fine.
Okay.
Good morning, Dr. Fishman.
Good morning. Good morning.
I'm Tariq El-Diasti from Egypt.
Hi. Well, it's not morning. It's noon. I guess for you guys, it's evening, right? It's 7 o'clock or something.
Yes, I'm talking from Dubai,
Really?
attending the Global Radiology Congress organized by the Royal College of Radiologists.
Oh,
yeah.
Sounds like a good place to be. I'm sure the weather's nice.
Yes, otherwise it's still hot. Yeah.
Yeah. Well, here it's not bad. Of course, we were here where we live. We're lucky. There was no hurricanes yet.
Yeah. It's very nice to have you with us today, and thank you very much for your time and support to the our Egyptian radiologists.
Yeah, hopefully. How are you guys doing with COVID? Are things better there now?
Yeah, it's better now. Yes. It's almost no restrictions now here.
Okay, that's good.
Yeah.
Yeah, here the only place that where I really see restrictions is in the hospital.
Yeah. The same in Egypt. Still, we have still face mask and some restriction in hospitals only.
Right. Yeah. I don't know when that's going to go away. I don't think anytime soon.
Hopefully it's over soon. Yeah.
Mm-hmm. Well, I think everybody's the same now. We thought it'd be over in a month or two, and now it's going on 3 years. So I think nobody wants to jinx it. I think that's
Yes.
Not much we can do anyway.
Yeah, sure.
So, Dr. Tariq, I think I'm going to proceed and introduce Dr. Illiot Fishman. Okay. So, so we can start now. Okay.
Yeah, sure.
Okay. So, hey everyone. So today is a unique session for our Radiology Interactive course held by the Egyptian Society of Radiology and Department of Radiology, Banha University. Today we have a special guest, Dr. Illiot Fishman. He's a professor of radiology at Johns Hopkins University.
Islam.
Okay, go ahead.
Yeah. Thank you, Islam.
Okay.
So it is a great pleasure and honor for me to introduce Dr. Illiot Fishman. He is a professor in the Johns Hopkins Medicine Department of Radiology and Radiological Science, Department of Oncology, and Department of Surgery. He serves as a Director of Diagnostic Imaging and Body Computed Tomography at Johns Hopkins and is a member of the Johns Hopkins Kimmel Cancer Center. His clinical and research interests focus on medical imaging with special emphasis on three-dimensional imaging and CT. He is a leader in the development of 3D imaging and rendering, including its impact on the uses in patient care and management. He was involved from the beginning in the development of 3D imaging, and over the last 25 years, Dr. Fishman continued to help develop 3D imaging and has been a leader in the development of interactive 3D rendering. His team is consistently at the forefront of research and development of new visualization and post-processing techniques and technologies. Dr. Fishman's extensive work in body CT has resulted in over 1,000 peer-reviewed publications, and he is the co-author and co-author of 10 textbooks. He is a recipient of 3 prestigious Antimony Awards, honoring his outstanding contribution as both an educator and researcher. In 2007, he was named by Medical Imaging magazine as the top radiologist in the nation. He is a member of editorial boards of more than 35 journals and active member of several professional radiology associations, and is a past president of the Society of Body CT and MRI. Professor Fishman is going to talk about multi-detector CT evaluation of gastric malignancies, bears, and pitfalls. Please, Dr. Fishman.
Okay, thanks very much. It's a real pleasure to be here. I'm glad you guys, I feel bad it's Friday night where you are, so hopefully I'll make it worth your time. So let me just share my screen here. I think some of you also probably know that we do a lot of stuff on the web. So we have CT is Us, probably a lot of you look at. If you don't look at that, you could probably, after this talk, you can look at it. Everything's for free and everything else. But anyway, we're still doing lots of development in CT. I think CT, you know, if you go back 20 years, it looked like CT was going to quote unquote disappear, but the evolution and revolution in CT continues. So I think it's very exciting. And I think CT is really the mainstay of oncology. It's the mainstay of inflammatory disease. So I think, and the apps that we all develop continue to grow. So I'm going to speak about, as mentioned, gastric malignancies, and just basically, you know, make the point. And one of the things I think we tell the fellows and residents and faculty, the single most important thing we do correctly is really protocols, that if you have the right protocols, then it's kind of easy to make diagnosis. And just for example, this is simply a routine CT with the stomach distended with water using cinematic rendering. And you can see how nicely you can see the gastric folds. And that's just a routine CT, nothing special. It looks like endoscopy. Or here, another example where I'm trying to look down the gastric antrum. Or here, where I'm looking at the stomach in a patient with abdominal pain. And there's an ulcer in the posterior wall of the stomach, which you can see very nicely here. The ability to detect disease, and this is true in the stomach, but essentially everywhere we use imaging is always dependent on technique. So if you can get the technique down well, and you'll learn some of the techniques that are being developed, like in 3D, cinematic is the latest and greatest of the 3Ds. You can see this is the kind of detail you can get. Or in this example of a patient with abdominal pain, you can see the stomach's well distended. There's high density in the stomach. The computer has a mind of its own, I'm sorry. But you can see the high density here. There's the lesser curvature. There's a break in the lesser curvature. There's a perforating ulcer right here, which is also seen very nicely here as well. There's the blood in the stomach. So we do put a lot of effort into trying to figure out what's the best way of showing disease for management, but also for detecting disease. I think one of the things, I've been very involved with AI, and this talk is not going to go through any AI, but I think one of the things we've learned with AI and we're learning is that radiologists often miss things. I don't care if you're in the US or Egypt. None of us are perfect. And it's the challenge, particularly with smaller lesions. Also, all of us are busier and busier doing more and more studies. And the more you do, the more the chance of missing something is. So I think one of the things we recognize that CT is more than just slices. If you only had slices, okay, that's one thing, but really it's volumes of data. And what this type of rendering does is gives you the information as a volume. So, and we've published, this is an article from a couple of years ago, looking at gastric neoplasms with 3D imaging, showing the increased value, both in detection as well as staging. And if you go online, I mentioned CT is Us, there are a number of lectures that are there on cinematic rendering. I have some new lectures that we put there. So it's worthwhile listening to that. If you're not doing it or you're thinking about doing it, it's probably worthwhile listening to. Now, I mentioned that everything we do is dependent on protocol. And for the stomach, I like to think of four things: good distension, opacification, the display we use for showing the information, and then things like enhancement patterns. So if you look at the stomach, the classic definition, a wall thickness under 5 millimeters, is probably the way we think of things now. It used to be 10 millimeters, but to me, under 5 is normal when the stomach is distended. The big thing is the stomach needs to be distended. I think one of the challenges we always had, but especially in the COVID era, when people were afraid to take people's masks off, the techs were not giving the patients oral contrast, be it water or positive contrast. And so everybody over the past almost 3 years now has gotten into a lot of bad habits. And I, for example, was at a meeting today with our technologists telling them, you got to give the patients oral contrast. It's critical to do that. And if you use positive contrast, we use water more now than ever. But if you're using positive contrast, the stomach is nicely distended. There's no wall thickening. You can tell the presence or absence of pathology. So, for example, in this patient with positive contrast, you can see the infiltration of the patient's gastric antrum and ulceration in this patient with adenocarcinoma. I prefer water, surely when I'm doing a dedicated stomach study, but here was a patient in the ER setting. So even patients you don't want to give positive contrast, or the ER docs don't want you to give positive contrast, everybody drinks water. So here's a good example of abdominal pain. And this patient had been seen a month before. The study was read as negative because the stomach wasn't distended. Here, the stomach is nicely distended. You see the infiltration of the body of the stomach by tumor. Or this example, where the patient came in for abdominal pain and had GI bleeding. They weren't sure of the source of GI bleeding. But if you look carefully here beyond the ascites, you look at the stomach, we gave the patient water. This high density material here, that's bleeding, okay? That's active bleed from what ends up being a tumor in the patient's posterior gastric wall. So again, the ability to detect the unexpected. You can see nicely here the bleed, particularly well shown on the MIP imaging. I give talks about GI bleeding. We do a lot of patients with GI bleeding on CT. Most of the time, people think about lower GI bleeding, which is really what CT is best at, and upper GI bleeding, endoscopy is best. But the reality is not every patient gets endoscopy. And the reality also is often you don't know the site of bleeding. Patient comes in with low hematocrit, low hemoglobin, maybe a positive stool. It just as well can be something in the stomach, as in this case, as well as in the small bowel or colon. And in this patient, there was no one knew in advance that it was going to be a gastric cancer, or you were going to see active bleeding very nicely shown. This case also makes the point, even if you don't have cinematic rendering and you have very minimal capabilities on 3D, it pays to look at MIP imaging. I like MIP imaging. I use a slab about 20 millimeters thick. I think MIP imaging is really good for looking at the kidneys and ureter and calyces. It's very good for looking at the vessels like hepatic artery and splenic artery and GDA. It's also very good for detecting sites of bleeding. The most subtle bleeding, whether it's in organs like liver or spleen, or it's in the stomach or colon, I think to me is best seen when you use MIP imaging. So I mentioned about the gastric wall thickening, 5 millimeters. The only place it's different is in the antrum. The antrum, even with good distension, can measure up to 12 millimeters. Here's a good example. You can see the stomach's well distended. There's the antrum. The key thing is when it's normal, when you look at a coronal view right through the center of the antrum, the wall thickening is the same bilaterally, and you have homogeneous enhancement. When you have a tumor, you can see the enhancement is not homogeneous. It's eccentric. The thickening is eccentric. Here it is on the coronal views right there, and you can see the infiltration. So although we will say the antrum can look thicker, it's not going to mean you're less sensitive for picking up disease. It's just you don't want to overcall things. So here's just a nice example of a gastric cancer. Where is that infiltration? You also can see in this example, routine coronal imaging works very nicely. Stomach is well distended. The gastric wall is very nicely shown. And then the transition in the antrum, where you see the tumor infiltration. And this patient is really developing gastric outlet obstruction at this point. Patients sometimes eat, and you can be fooled at times, but when you have this much fluid in the stomach and you have a lot of residual food matter, which you see up here, to me, it means the patient must have gastric outlet obstruction. Now, it could be due to benign disease or it could be due to malignant disease. In this case, when you look at the antrum, you see it's really thickened here. And then you look at the sagittal views. Here's the stomach. There's the antrum. You see how it's really thickened, but there's asymmetric enhancement. There's decreased attenuation here in the submucosal region. That's very classic for an infiltrating tumor, typically going to be an adenocarcinoma. So for us, the way I like to do, if you give me a dedicated stomach study, 1,000 cc's of water given over about 20 minutes, or you can use positive contrast. If we can't give IV, I'll always use positive contrast. I like IV. We use Omni, injecting about 100 cc's or so at a 5 cc's a second. Our routine protocols for abdominal pain without anything specific in the ER perhaps would be a single phase in the venous. But if you tell me that I'm staging gastric cancer, or I'm trying to rule out gastric cancer, or I'm worrying about a bleed, then I'll do dual phase arterial at about 30 seconds and venous at about 70 seconds. There's value in doing dual phase imaging in that scenario. Now, I mentioned I like water best for looking at the stomach rather than positive contrast. The one exception might be a case like this where you're worrying about a fistula. This patient had bad breath. Here's the stomach. Something's going on here behind the stomach. You can see when you give positive contrast, there's a fistulous tract between the stomach and colon, this gastrocolic fistula, which was a cause of the patient's symptoms. But fistulae are always better seen with positive contrast. Same thing in the colon. If I'm looking for a fistula from the rectum, I'm looking for a fistula from rectum to bladder or colon to small bowel, I really like positive over neutral contrast agent. As I mentioned, typically routine abdomens are about 70 seconds post-injection, but if I'm really focusing on a specific problem, I will do dual phase imaging. Now, if you ask me in gastric cancer, what's better for what reason, I'll say venous is best for looking at liver mets because they're typically hypovascular and that shows better in venous phase. It's also best for defining small nodes because if you only had arterial phase, particularly in patients who have cirrhosis, you can confuse nodes and varices. And also, particularly when you try to pick up subtle tumors, arterial phase may be too early to appreciate subtle changes in the mucosa and submucosal enhancement pattern. So just a good example, this is a patient with just some mild gastritis, thickened wall. Arterial phase, you can see the wall thickening, but there's not a lot of enhancement. On venous phase, you see the enhancement a whole lot better. And so when you look from a sagittal view, there's the decreased enhancement. And one of the things you look for subtle tumors is a differential between mucosa and submucosa in terms of enhancement. If you only had arterial phase, you may not appreciate those findings. The other thing is this was a patient who was sent to us for a gastric mass. You look, the patient has cirrhosis on the arterial phase. To me, I'm always very careful. If I only have one phase and it's arterial, I'm always concerned about overcalling something because patients have a lot of different patterns of varices, and varices look like nodes or masses. So this thing, which was sent to us for evaluation and biopsy of a gastric mass, is simply large varices when you have venous phase imaging. So to me, once I have any cirrhosis, I'm always exceedingly careful not to make a mistake. So gastric cancer, epidemiology, you have 650,000 patients worldwide. Certain parts of the world, like the US, the numbers have gone down over time. Certain places like Japan, it's gone up. It's rare before age 40. The biggest challenge to us is that despite a lot of efforts, it's often picked up when the patient has significant spread of disease. It's hard to pick up early gastric cancer unless you really have good protocols and you think about it. Now, there are risk factors. H. pylori is the classic one, but things like pernicious anemia, menetriase, which is rare, and post-resection stump cancer, which is rare. Patients often can have associations with syndromes, and there's about 10 different syndromes with increased incidence of gastric cancer. I'll just mention Peutz-Jeghers is one of them, that those patients, although we think about polyps in the small bowel and colon, a third of patients almost will develop cancer during their lifetime. So you want to be very careful if you're evaluating these patients and you're looking at the small bowel and colon, make sure you take a good look at the stomach as well. When you look at gastric cancer in general, the distribution from fundus down to antrum is pretty similar with diffuse infiltration, about 10% of cases. When you look at the literature, the accuracy of staging is totally dependent on how you look at the images, including protocol, meaning gastric distension, as well as if you're looking at axial only or multiplanar images. The things that are important to us as radiologists, detecting the tumor and extent, local spread of disease, and distant metastasis. That's really going to define the stage of disease, of course, and how patients are managed. In terms of appearance, the earliest appearance will be focal thickening. And the biggest challenge with picking up early gastric cancer is not overcalling everything. If you called everything above 5 millimeters abnormal, you'll pick up some early gastric cancer, but you'll be picking up a lot of patients with gastritis, far more than with cancer. So it is a challenge. As lesions become larger, polypoid, diffuse wall thickening, bulky tumors with ulceration, or diffuse infiltration, it perhaps is easier to diagnose, but again, you're diagnosing later stage of disease. So when you look at the staging, typically CT, if you're good, you're picking up in the T2 level, but most patients we do see are really picked up about T3. It's hard to pick up early disease. Now, people have tried, I mentioned one of the simplest things is measuring gastric wall thickness. And this article, this is a number of years ago, but it made the point if you use 1 cm or greater, you had a sensitivity of 100%, but your specificity was really low. Now, on the other hand, instead of thinking about just wall thickening, if the wall thickening is very focal, if it's eccentric and has increased enhancement, in that scenario, the majority of patients are going to have cancer. So again, I'm looking with good distension, focal thickening, abnormal enhancement, and often you can see ulcerations. So if you look at this case, it's a nice simple example, 3D and axial. Stomach is well distended. There's the air. You can see this mass here, focal wall thickening. There's an ulceration. It's eccentric. Not very difficult to call that a gastric cancer. Or in this case, if he asked me the most difficult areas, I would say the GE junction. The problem is it's easy to overcall things. This was read as negative. Now you look and you say, well, what was the person thinking? Maybe they thought the patient had hiatal hernia or something. But there is some calcification or enhancement here. And if you look at it a little bit closer on the coronal, you can see this asymmetric thickening with calcification, which means you're dealing with a mucinous tumor. This is not simply lack of distension. This is tumor infiltration. And I think on the 3Ds, or at a minimum, the coronals, forgetting the 3Ds for a moment, you're going to appreciate that better. I do like the volume rendered images, which these are. I think it's a good way of picking up disease. Now, the most common place gastric cancer goes is to nodes. Typically with nodes, we always say 1.5 centimeters or better. We worry about tumor in nodes. But with gastric cancer and esophageal cancer, you have to call things earlier. Typically, people will talk about nodes over 8 millimeters. Any node 8 millimeters or greater around the gastrohepatic region, by the lower esophagus, by the gastric fundus, anything 8 millimeters, even solitary nodes, are going to be concerning. There's one article basically looked at each nodal group, and you can see it's a busy slide, but they looked at maybe 8 nodal groups around patients with gastric cancer, and you could see things measured from greater curvature, 6 millimeters, suprapancreatic, 9 millimeters. To me, I think if you say anything above 8, some people might argue 6 millimeters, everything to me becomes suspicious at 8 millimeters. And I think then your accuracy is probably going to be in the low to mid 80%. If you wait to 1.5 centimeters like we typically do, you're going to miss a lot of nodes. Okay, so that 8 millimeter thing is where I kind of put my stake in the ground. Now, obviously, you can have bulky adenopathy. Here, the patient has an infiltrating gastric cancer. There are a lot of nodes peripancreatic. There's encasement of the patient's celiac axis. This was a great case. This was a patient actually who was referred to pancreatic cancer conference for pancreatic cancer. There's a mass, it looks like, in the pancreatic head. When they did a study, it was an outside scan. The stomach was not distended. We did the study. The stomach's distended, and actually you find a mass in the stomach. And when you look, it's hard to, you look at the pancreas, there's no dilated pancreatic duct. You realize these are nodes in the portal caval space. And what this patient had was not pancreatic cancer, but had gastric cancer with nodal disease. So here's the gastric cancer. Here's the nodal disease peripancreatic, and lots of nodes in the para-aortic region as well. You can see small nodes up here, but a gastrohepatic ligament. Each one of these nodes would be positive, aortic caval nodes. This is kind of a good look at distribution of nodes. So that's important. The other thing important for the surgeons is spread of disease. And this article made the point that staging disease, particularly more advanced disease, is much easier when you look at the coronal planes. Now, this patient, nothing's very subtle. There's liver mets, there's ascites, there's a bulky gastric tumor. But if you look at the coronals, here's the stomach, there's the tumor infiltration, and you can see it grows down the gastrocolic ligament onto the colon. That's a very common pathway of spread. Now, in this case, patient stage 4 just from the liver, but it does make the point that you want to look at things in the coronal plane. Even if you're not used to doing that in practice, if you want to stage patients, you really have to do that to be accurate. In terms of spread of disease, we look at nodes first. Then I look at the liver. Liver mets from gastric adenocarcinoma are typically hypovascular. They can be small, they can be large, they can be multiple, as in this case. Sometimes the tumor is small and the liver mets are pretty extensive. We also look carefully at the omentum. Gastric cancer spreads on the omentum and in the mesentery. So you can have what seems like localized disease, but then here you can see the spread on the omentum. Classic carcinomatosis, you see the ascites. When I see ascites in gastric cancer, to me, it's always going to be that the patient has spread beyond the stomach. Here's that same patient. There's the antrum of the stomach. There's the tumor infiltration. And you can see on the omentum this little haziness and nodularity. Classic carcinomatosis. And here it is on the cinematic rendering as well. Now, in this example, we also look at the presence of spread. So adjacent organs. This patient actually was thought to have pancreatic cancer. It was really a gastric cancer that invaded the pancreas. So it is possible for gastric cancer to directly invade the liver, directly invade the spleen, and directly invade the stomach. You can see here this big ulcer, and again, direct invasion by the tail of the pancreas. We also always scan through the pelvis. One is to look for carcinomatosis. Gastric cancer can give you implants on the colon, rectum particularly, but also it metastasizes to the ovary. So Krukenberg tumors are one of the classic things. Not all ovarian mets are Krukenberg tumors, but the classic primary sites for mets to the ovary are stomach, colon. Sometimes the patients present with pelvic pain and they have no known gastric cancer and they have an ovarian mass, and the ovarian mass is biopsied or resected, and then it ends up being metastatic gastric. So again, you got to think about that possibility when you're looking. If you ask me what the problems, what do we have, even with the best protocols, sometimes the lesions are just really small. They're subtle, flat lesions. Even in endoscopy, you have a real problem doing it. There is work now with AI looking at endoscopy to try to improve detection of small tumors. It's difficult to define the exact depth of penetration on CT, so that's a little bit of a challenge. And as I mentioned, nodal involvement as well. Now, gastric cancer can perforate. One of the challenges is, like in this case, there's infiltration here and there's perforation. When you have perforation of the stomach, even if it was a benign ulcer, but surely malignant, you have this stranding around the stomach, which is seen nicely here. And I always look at the stomach and the fat around the stomach to look for early spread of disease. So when you look at this case, you're going to say, I'm worried there's infiltration in the omentum, but you have to be very careful. When you have an ulcer and the ulcer perforates, you can get false positive tumor spread because it's the ulcer and the local inflammation that's making it look like there's tumor spread on the omentum. So I think it's very important that if you have an ulcer, I'll always say there's an ulcer, there's some stranding there. It's possible it's spread. I can't exclude it, but perhaps it's simply inflammation. I don't want to upstage patients and take their chance of resection away from them. So that becomes very, very important. Here's another example of a perforation right here of an ulcer, and there's all the stranding. In the right scenario, this could be carcinomatosis on the omentum, but this is simply inflammation. This patient was resected. There was no tumor spread, but it's something that's a pitfall and something I think you need to worry about. Now, when you get past gastric cancer, then we talk about lymphoma. Lymphoma have small numbers, but we are seeing lymphoma more commonly now. Immunosuppressed patients would be one example. We typically see mainly non-Hodgkin's lymphoma. When you have gastric lymphoma, it could be part only of the stomach, or it can be multi-organ involvement. In terms of GI lymphoma, there are typical risk factors: celiac disease, patients with HIV or AIDS, patients who've been immunosuppressed. So one of the things is patients, for example, with psoriasis who get immunotherapy treats the psoriasis very well, but those patients have an increased incidence of lymphoma. Patients with celiac disease have a 200-fold rather, increased risk of developing GI lymphoma. So that becomes very, very important. In the old days, when people would say, how do you differentiate gastric adeno-CA from lymphoma? You would typically say wall thickening over 5 centimeters is lymphoma. Under 5 could be adeno. Adenopathy is much bulkier, and with lymphoma, the adenopathy extends beneath the renal hilum. With gastric cancer, it stays above the renal hilum. Now, a lot of that is true, but we pick up gastric lymphoma a little bit earlier these days. So those large, bulky masses, I don't see that commonly. And I think sometimes lymphoma and gastric adenocarcinoma look identical. Obviously, no one's going to get treated without a biopsy, but it's something to consider. There's lots of overlap. Again, extension into duodenum, bulkier nodes. Then I'm thinking about lymphoma. Again, I mentioned H. pylori is one of the important factors with gastric adenocarcinoma. It's also associated with lymphoma as well. In terms of lymphoma, here's just a really good example. This patient had abdominal pain, and this patient has diffuse infiltration of the antrum, and stomach's nicely distended. You see the thickening going through the antrum. That's a tumor. And I read this case. I thought this was going to be carcinoma. It's about 15 millimeters in thickness. There's some ulcerations, great location. I didn't see much else. I thought the patient would be resectable. This was biopsied. This was lymphoma. It's a really good example of showing the overlap between lymphoma and gastric cancer. You can see it here as well. It can be challenging. Here's again some more images in that patient, a coronal view and a sagittal view. Look at the infiltration. Very much looks to me like adenocarcinoma. I still would pick adeno as the likely diagnosis. The patient doesn't have substantial nodes. So particularly early on, there is some overlap. Here's a cinematic. With lymphoma, obviously, you're more likely to have splenic involvement. With adenocarcinoma, more likely liver involvement. But again, a case like this where there's no other organ involvement, it can be somewhat of a challenge. Now, lymphoma, as well as almost any gastric tumor, including adeno, can present with GI bleed. This patient had guaiac-positive stools. You can see the stomach, the wall looks thickened. There's a lot of residual food matter in the stomach, maybe some clot. To me, I looked at this, the stomach is definitely abnormal. It could be severe gastritis, to be fair. We've had patients with really bad gastritis with wall thickening, but you have to exclude the fact that this is a carcinoma. And to me, I thought this was a carcinoma. It ended up being lymphoma. So lymphoma often will pick up gastric involvement as part of multi-organ disease. You have a patient with disease in the liver and spleen and kidneys, big-time adenopathy, then it's easy to pick up gastric lymphoma and be very specific. It's the cases we pick up earlier now where the stomach is thickened, but not a whole lot different than adenocarcinoma. I think it's challenging. Third tumor are GIST tumors. Now, I don't know about your guys' practice in Egypt, but here, GIST tumors, which I rarely saw, are really becoming more common. That's true in stomach and small bowel. In fact, in the US, over the past 30 years, the frequency of GIST tumors has increased by about fourfold. Gastric GIST tumors make up about 70%, and small bowel is about 20-ish%. But GIST tumors can occur anywhere from the esophagus to the rectum. They have certain path characteristics, CD117 positive, CD34 positive. They're unusual tumors. In the stomach, the most classic GIST tumor is going to be an eccentric mass, but it can be intraluminal. Not all GIST tumors are malignant, about a third are, but typically when they're over 5 cm, they're essentially always malignant. And if you look at the path reports, even when they don't look malignant, they're 3 cm or 4 cm, the pathologist will say, I don't see signs of malignancy, but I would follow this patient carefully because I can't exclude that the patient can develop malignancy. So malignant risk, exogastric location over 5 cm. Again, path, mitosis greater than 1 per 50 high power field. At times, GIST tumors are tricky because they're exogastric masses and can be very large. They're not hard to recognize, but you may not be able to tell, is this a gastric mass? Is it a pancreatic mass? Is it an adrenal mass? Or even sometimes maybe it is a splenic lesion. These lesions are sometimes homogeneous, but often they're necrotic in appearance. Mets commonly go to liver, and we talk about cystic liver mets. There aren't too many things that give cystic mets. One is ovarian cancer. The other big one is GIST tumor, and maybe the third would be melanoma. Now, sometimes the GIST tumors are nice and small. Stomach's well distended. Here's a 3 centimeter mass, minimal enhancement, sharply defined. Here's another one. These are the ones that really have benign courses. These are the ones that are going to get partial gastrectomies. And again, nicely shown. And they're intraluminal. Here's another one. This is a lot larger. There's irregularity of the wall, but also it's sitting in the lumen of the stomach. And then here's a second one. GIST tumors can be multiple, but this is a large mass. It's necrotic. There's no doubt that, and it was malignant. Partial gastrectomy is still a treatment of choice. Patients with these tumors will often get Gleevec. Gleevec can shrink the tumors, and then the patients will become resectable. You can see how bulky this tumor was and its infiltration into the gastric wall. So nothing very tricky there. There aren't that many tumors that are bulky, that project in the stomach like that. Could be an adenocarcinoma. It still would be in the differential. Could be metastasis, but GIST tumors are classic. The most classic appearance to me, however, for GIST tumors is really looking at these exogastric masses. Here's a smaller one, about 4 cm, coming off the stomach. Nicely shown there and there as well. Here it is on the cinematic. I think the biggest challenge sometimes for these lesions, is it abutting the stomach or arising from the stomach? That's a challenge we often face with many diseases when things simply abut. You can see how large these lesions can get. Exophytic, it's growing directly into the spleen. So these lesions can go directly into adjacent organs. Spleen might be the most common. It can grow down to an adrenal bed or to renal. And in this case, you also can see some calcification there as well. But you can see large tumor. Here's another example. There's variable enhancement. This one's a little bit more vascular. Again, if you see a bunch of these, you kind of recognize, no, this is not a splenic mass. No, it's not a tail of pancreas mass. This is a primary gastric mass, exophytic. You can see how large it is. A very classic appearance. There's some ulcerations, but it's really a large exophytic mass. Sometimes if I'm uncertain, the coronal view is really nice. You can see the tumor coming off the stomach. There aren't that many tumors that grow exophytic in the GI tract. The most common one, be it in stomach, small bowel, or colon, is going to be a GIST tumor. These tumors can ulcerate. That's not a great surprise considering how big they are. They can present with GI bleeding. They can present with ulceration. You can see that here. Once patients get Gleevec, the tumors often will necrose. So if the patient's under chemotherapy, which is typically Gleevec, and the lesion has increased lower density compared to prior studies, it doesn't mean that's anything bad. It means the patient's responding to the Gleevec. But again, necrotic tumors, GIST tumors can perforate. Look how bulky this tumor is, exophytic with the ulcerations, and concern always is perforation, though I have not seen that many of them. Again, another example, large tumor, big ulcer, big exophytic mass. Again, just showing you a bunch of different views. I think that appearance here, to me, is probably going to be the most helpful appearance. And here it is with cinematic. So does the cinematic add anything here? Probably not, but I think it gives a nice view of the tumor. Often the surgeons will use those informations as part of surgical planning. GIST tumors can calcify. You can see nicely calcified here. Most of the time when you have a calcified mass like this, it's usually what we would typically have called leiomyomas, but it's typically, will be read now as a possible GIST tumor by the pathologist. But these tumors do well. They could be resected, but they're often followed because it's a very low malignant potential. So it's kind of a nice exophytic appearance, but the lesion's nearly entirely calcified. There's not many gastric lesions beyond GIST that are going to calcify. So that's the diagnosis. Now, here's a good example of a GIST tumor. This was actually read, and I could see why, as a pancreatic mass. Here's the tail of the pancreas. It looks like this mass is coming off the tail of the pancreas. Maybe it's a neuroendocrine tumor. Maybe it's a SPEN tumor. And you just say, well, it's pancreas touching the stomach. Pancreatic tumors, when they get large enough, often touch the stomach. So maybe that's not a great surprise. But that was actually a GIST tumor. Here's another one. Again, talking about the size. Here you can see implants. So this is a good example showing you what GIST tumors do. Cystic liver mets, omental implants, nodularity here. So they can spread, they can be very aggressive. And here's some more images in that patient. Multiple omental implants. Look at the size of this, about a 7 or 8 centimeter implant. There's implants here by the kidney, near the adrenal bed. There's implants here on the spleen. So GIST tumors can be very, very aggressive in terms of spread. Now, sometimes they can fool you. Here's a good example of a large mass that was called an adrenal mass, and it ends up being a GIST tumor. Again, here's the adrenal. Yes, we can see the adrenal when we look hard, but quickly, when you're looking, it looks like an adrenal mass, maybe adrenal cortical carcinoma, which you can see very nicely. So I think that becomes very, very important to us. You want to be very careful. GIST can be confusing. And I'll just leave it at that. And I think sometimes on CT in general, when you have very large masses, it's easy to find the mass, but where the mass is coming from can be a little bit more tricky. And just a really nice example, this patient had the tumor resected, the patient had chemotherapy, and we followed the patient, and the patient's doing great. So just a really nice example of a patient literally who was presented. I read this case at a adrenal conference for a suspected adrenal cortical carcinoma, and I was pretty convinced it was simply a large GIST tumor. And again, I showed you an example before, but you can see where people make mistakes. Here, it looks like maybe it's just touching the stomach or maybe touching the pancreas. And you can argue, is this coming from the stomach? Is it coming from the pancreas? This was coming off the stomach. This was a GIST tumor, really simulating a pancreatic mass. So it can be tricky at times. You got to think about that. If you've seen a bunch of these, you kind of get used to it, but it's hard. It's hard. And at times you will be confused. And then obviously you get a biopsy and you'll get the right answer. Here's another one. Again, this was sent to us as a pancreatic tumor. It was a young patient. They thought it was a SPEN tumor, solid and papillary epithelial neoplasm. And I have to admit, if I read these images myself here, this to me looks like a pancreatic mass. Even on the coronal views, looks like a pancreatic mass. But this was eventually resected. There was a very tiny plane to the stomach. On these images, it looks like there's a clear plane, but in some of the images, it wasn't. Now, what else can look like GIST tumors? Well, occasionally bulky lymphomas, and I showed you lymphomas, so that can look similar. This was a case we all were sure was a GIST tumor. It's a huge mass arising off the stomach, we thought. This was biopsy, it was a liposarcoma. Liposarcomas are the most common retroperitoneal mass. They usually contain fat, but not always. This one has no macroscopic fat, just ended up microscopic fat. And so we saw this big mass exophytic to the stomach or pushing on the stomach. We thought it arose from the stomach, and we thought it was a classic GIST tumor. So again, you're not always going to be right. At times, you can be confused with pancreatic lesions. You can be confused, like this case, with a liposarcoma, but usually you'll be right. Now, other tumors in the stomach, if I see a vascular lesion like this, and then here's vascular nodes, I'm thinking of something like a neuroendocrine tumor. The most common tumors in the stomach that are vascular are carcinoid tumors, which this is. You also can see gastric rests. You can see ectopic pancreas be vascular, but you got to be thinking carcinoid, particularly when you see nodes present. They can be very subtle. You look at the stomach here, you're not all that impressed. When you get down to different cut, there's a 1 centimeter mass that's vascular. Is there anything else I could think about? Oh, yes, I've seen a case of metastatic renal cell, but the kidneys look good here. So gastric carcinoid tumors are typically small. You can have multiple gastric carcinoid tumors in some syndromes. Here's a good look at the coronal view. You can see it's a nice flat lesion, which can easily be resected right there. Here's an example with multiple polypoid lesions in the stomach. These were all carcinoid tumors. If you look at it, you can say infiltration. You could say, well, could this be lymphoma? But they're kind of polypoid. Adenocarcinoma doesn't look good for that. It looks like polyps. Look at them. You can see they're enhancing here. These are multiple polyps, and you could get this with neuroendocrine tumors. Look at this is the look on the cinematic rendering. You see all these masses? These are all multiple carcinoid tumors. So there are syndromes that give you multiple carcinoid tumors. So that can indeed occur. It's pretty uncommon, but it's kind of a super cool example. So another patient, this patient had gastrinoma, so a pancreatic mass. Those patients often get carcinoids in the stomach, and they can be multiple. Look how the stomach is infiltrated. I might think about lymphoma for this case, though it's a little bit vascular for lymphoma. But when you look hard, these are all polypoid lesions. And here's the patient's pancreatic mass. There's a duodenal mass. This is the gastrinoma. which metastasize to the patient's stomach. These are all polypoid lesions. So again, you can see polyps, gastric polyps that are benign. Some people have a couple, some people have a lot. But when you see things that are enhancing like this, you're not thinking about benign polyps. You're thinking about malignancy. And these were carcinoid tumors, very nicely shown. And the image on the right shows you some of the vascularity. Glomus tumors are another tumor, submucosal lesion that's enhancing right here. So again, in that differential. Again, the importance of good gastric distension, the ability using IV contrast so the lesion enhances very nicely. And here it is again with an endoluminal view, kind of like a view with the endoscopist. That lesion is just sitting as a polypoid mass that will be resected. Now, I'll also mention one of the reasons protocols are important. There are lots of tumors that metastasize to the stomach. The classic is breast cancer, which gives you a linitis plastica appearance. But we're seeing more these days with metastatic melanoma, be it multiple or solitary masses. Breast cancer, as I mentioned, often the patient has no known recurrent breast cancer in terms of the primary bed. And as a year or two later, they're having abdominal pain, you're looking for a source, and it ends up being this linitis plastica. If the stomach is not well distended, you really don't recognize it. You can see here, you might say, well, maybe the stomach's not distended well, but you see the mucosal enhancement and the infiltration of the submucosa. Obviously, you see ascites, you see adenopathy. Very classic linitis plastica. Here it is with the cinematic. Very classic appearance. Another example here. Again, look at the thickening. Again, the importance of correct protocols to distend the stomach. We tell the techs that all the time. And here's just a good example where the patient's abdominal pain was not pancreatitis, which was the clinical suspicion. It was diffuse infiltration by linitis plastica. And of course, this patient also, as you can see, unfortunately, has widespread bone metastasis. I mentioned melanoma. We are seeing, in the world is seeing more melanoma. And I think, unfortunately, with global warming and a lot more sun, the incidence of melanoma is increasing substantially. All skin tumors are increasing. Melanoma is a great mimicker. This is an example of metastatic melanoma to the stomach. I have to admit, I looked at this case and I thought it was a GIST tumor, exophytic lesion coming off the stomach that ended up being melanoma. And look at all of these multiple masses here within the lumen. Melanoma is one of those tumors where you have multiple masses present. Here's another case. This was a patient with GI bleeding and had renal cancer. You know, renal cancer, particularly even with partial nephrectomies of papillary tumors, anywhere between 5 and 10 years after original resection, patients can develop mets, commonly go to pancreas, and go to stomach. This was a polypoid mass in the stomach. I didn't know what this was exactly. Look at it on the coronal. Large polypoid tumor. Maybe it's an adenocarcinoma. Patient has ascites, liver mets. This was biopsied. This was metastatic renal cancer to the stomach. So again, when we look at patients with follow-up renal cell, take a good look at the stomach and take a good look at the small bowel. It's not uncommon for us to see metastasis there. And look how bulky this lesion was in the stomach. And of course, on the cinematic, you also see all the liver mets. I'll just mention, not everything we see in the stomach is going to be malignant. In fact, most lesions are polyps. They're benign tumors, neurogenic lesions, lipomas, hyperplastic polyps. Sometimes it's tricky. This patient had GI bleeding. Here was a polypoid lesion. Obviously, I thought this was a cancer. It's enhancing. This was resected, an inflammatory polyp. This patient was very lucky. Again, from an imaging perspective, I think our job number one is lesion detection, then it's classification. And you're not always going to classify things correctly. I mean, if I see an enhancing polypoid lesion, A, it's coming out, but B, I'm worrying about malignancy. Here's another patient. Here's this polypoid lesion. There it is right there. Could it be an infiltrating adenocarcinoma? I thought I picked up an early cancer. Nice example. This patient's lesion was biopsied before surgery. This ended up being heterotopic pancreatic tissue. So I mentioned ectopic pancreas, most commonly is in the duodenum, but can be found in the stomach, particularly the antrum. This case is in the body. So again, my accuracy was really good for finding a lesion. My accuracy was not that good for determining its cause, but those rare cases are always going to happen. And it's kind of an interesting diagnosis. Most of these heterotopic pancreas are very small and you really don't visualize them well. Others can be like this case. Other things that happened, this stomach was relatively well distended. Patient had weight loss. I looked at this and I said, okay, this looks like an infiltrating tumor. You have to biopsy it. This ended up being an ulcer. You can see the ulcer here, but it was no malignancy. So I think at times with inflammatory disease, even very focal disease, when we see focal disease with ulceration or focal thickening, we're always saying suspicious for cancer. And it's really the biopsy that's going to give you the answer. Now, I will admit sometimes, including this case, even when the biopsy was negative, I was sure this was cancer. And I told them to rebiopsy because sometimes they biopsy superficially and you need deep biopsies. This was rebiopsied. I was still sure it was cancer. They told, and I said, rebiopsy it again. They told me if I want to biopsy it myself, I can, but they're not going to do it again. And this ended up being an inflammatory ulcer with lots of focal thickening, but it was not a tumor. So you can be fooled at times. Here's another example. You know, it just looks like an infiltrating tumor. Look, stomach's well distended, ulceration. So once you have ulcers, focal thickening, as a radiologist, I think we need to worry about cancer. The patient will get endoscopy, will get biopsied, and every once in a while, the patients are going to be lucky and it's going to be a cancer, not a cancer, but an ulcer simulating a cancer. There's also new things that come along. This has diffuse infiltration of the stomach. I was worried about malignancy here. I did consider gastritis. This patient was being treated for melanoma. So I worried about, could it be Mets to the stomach? This patient was on immunotherapy. Now with melanoma, some of the new immunotherapies can really give you severe enteritis. We've written about that, but it's also important to remember it can also give you severe gastritis. And this is a great example of gastritis simulating tumor. Look how it looks like it's infiltrating the stomach. This was gastritis. So a lot of these new medications, a lot of the immunotherapy does miracles to patients, but initially it can cause all sorts of problems. And so you need to be a little bit careful. But again, I described it and I worried about infiltration. Could it be inflammation? Yes, but I sure worried it could be malignant. And there's a really nice look. You can see, look at this is cinematic. Look at the infiltration. And the patients get very, very inflamed stomachs and inflamed small bowel and inflamed colon, but they get past that and the patients are doing amazingly well. So I've gone through a lot of stuff and I've gone through it at night. I know it's about 7 o'clock, I think your time. I think the biggest thing to me, and when I tell the residents, fellows, faculty, is technique. If you do the right technique, you're going to pick up early lesions. There are classic appearances for the various tumors, but they're not always going to be classic, and there is overlap. So I think sometimes we'll suggest it's adenocarcinoma and it ends up being lymphoma or vice versa. There are potential pitfalls. Again, we don't want to miss a cancer. So at times you're going to pick up lesions and it's going to end up being a benign ulcer, but that's all right. We're picking up the process. And again, the differential diagnosis, the challenges we have in differential diagnosis, the importance of accurate staging. And I think I also showed you a little bit about 3D imaging. I really like 3D for a lot of things. I think the challenge probably for you guys as well as for us, everyone's really busy as radiologists. How do you have time to do additional stuff? I think that over the next couple of years, one of the things AI is going to help with, it's going to create the 3D maps for you. So instead of you spending time doing it yourself, the computer is going to create the 3Ds, not just simply to say you have 3D available, but here's the 3D images. So with that, I'll stop there. And I thank everybody for their attention. So I'll have to visit Egypt one of these days, but until we get past COVID and everything, let's see. Where
Yeah.
can we, CTSO's website, I'm just looking really quickly at the, some of the questions. Yeah, www.ctisus.com. It's for free. There's a big teaching file. Look at the stomach. There's a bunch of lectures. There's a ton of stuff. And actually it's, we started the website in 1999, so it's 23 years. So it's pretty good, I think.
Dr. Fishman, do you have time for the questions? Like we have like 3 questions or something.
Okay, sure.
Okay, so how to differentiate between Krakenberg tumors and bilateral ovarian malignancy?
Yeah, I think sometimes it's impossible. I've seen patients, where as I mentioned, patient has ovarian mass, they biopsy, assuming it's an ovarian cancer, it ends up being gastric. And I've seen patients with nothing in the stomach and it ends up being Krukenberg as well. I think that's really a path diagnosis. I think the big thing to me is if I'm staging gastric cancer, I'll look very careful at the ovaries. And if I think there's anything abnormal, I'll make the suggestion. But there can be a lot of overlap. We published an article about that. We looked at it, from a radiologist's perspective, the radiologist would always get it right when there was a big gastric tumor. But if you only showed them the pelvis, and then not show them the stomach, it was really impossible to distinguish because both patients with Krukenberg often have ascites, patients with ovarian cancer often have ascites. So I think it's impossible if you only looked at the pelvis. To me, as if I see a gastric mass and then I see ovarian, then I'm suggesting Krukenberg, but it'll be up to path to make the diagnosis.
So second question is how to differentiate between well-defined GIST tumor and leiomyoma of the cardia?
Yeah, I think what happens, how do you differentiate the two of those? I think it's really a size thing. I know the pathologists, everyone looks at high power field. Once something is 5 centimeters, the pathologists always call it suspicious for malignancy. Over 3, they sometimes even call it. So to me, if I see something very smooth and homogeneous and it's 3 centimeters or less, I'll suggest a leiomyoma. Once it gets to 5, I'm saying it's a GIST tumor till proven otherwise. And I think what happens everywhere is they resect it, by us at least, they're going to be resected and they're going to be followed. But the pathologists, even when they read it as leiomyoma, they always kind of have this disclaimer on their report that says, looks like a leiomyoma, but sometimes early GIST tumors can look like leiomyomas. So it's almost impossible to say it's not an early leiomyoma. So what they'll do is simply resect it and just follow the patient.
All right, thank you. Thank you.
Thank you very much, Dr. Fishman. It's a great honor for us to participate our radiology department at Penn University and the Egyptian Society of Radiology in this very unexceptional session today. Hoping to share us again in other sessions, Dr. Fishman. Thank you very much.
It'll be a pleasure. And I wish everybody a great night and a great weekend. And it's been an honor to be here.
Thank you.
Thank you very much.
A great weekend.
دكتور عزة سامعيني صح؟
سامع حضرتك. السلام عليكم.
اوكي عليكم السلام. اوكي معانا دكتور هشام الشيخ رئيس قسم الاشعه جامعه بنها.
دكتور عزة ازي حضرتك؟ منور الدنيا، الله يكرمك.
اهلا بحضرتك.
يعني انا اتشرف بمشاركه حضرتك ان شاء الله، تكون يعني محاضره مفيده للجميع ان شاء الله. شكرا جزيلا.
شرف ليا والله، يعني بشكر حضرتك على الانفيتيشن وربنا ييسر ان شاء الله وتبقى يعني
ان شاء الله
في فاليو فيها. هو انا بس قبل ما ابدا، هو في يعني انا can I interact مع الريزيدنتس ولا انا يعني present كل حاجه؟ يعني fine either way if you want me.
You can interact.
دكتور عزة ممكن يبقى ده بيتر يبقى في interaction مع
اوكي، عشان يعني هي طبعا يعني أنا I'm gonna share my screen if you don't mind. Okay. Share. And just let me know if you see my screen, okay?
تمام شايفانا.
طبعا يعني أنا اسمي عزة الجندي, assistant professor at University of Pittsburgh Medical Center. And this lecture is kind of a little bit of, like basic chest radiology, which is chest radiograph. This project, actually, 2 of my residents are working on it to be, like presented for the thoracic imaging, the cardiothoracic imaging at the RSNA. Again, it's a very basic lecture, but my main target from this is to show the value of not to miss like a cancer on chest x-ray, since all of us as a chest radiologist read at least like 100 cases every day, and we don't expect to exceed like 1 minute reading a chest x-ray. So sometimes, like we can easily overlook cancers or suspicious nodules. That's why the main target for this study, and also, like the main idea is not to miss like a small cancer or something. Again, it would be great if I can have like a participant from, like the residents. I understand I will walk them through the case. It's all x-rays, so it shouldn't be hard. But again, the main is radiologists must be familiar with certain blind spots identified on the PA and lateral chest radiograph to diagnose suspicious nodules or cancers. And again, during this presentation, we will be trying to identify like 8 blind spots. Before you sign off on any chest x-ray case, try to make sure to have targeted look to these blind spots so not to miss a cancer. This paper, I always tell all my residents, especially R1, they have to understand this paper very well. It was published in 2007, Radiographics. It's called Lines and Stripes. The main difference between this paper and the work we're doing is this paper talks more about mediastinal lines. So they recognize like 10 important lines, and, like for us, if there is like a hiatal hernia, aneurysmal enlargement, AP window adenopathy, if we follow the 10 stripes and lines, which was introduced in 2007, very unlikely for a first-year resident to miss important finding on the mediastinum. Our presentation...
Excuse me, we cannot see anything. I think we just see the main screen of PowerPoint, and
you don't see screen? That's bad.
We just see the main screen PowerPoint, Microsoft PowerPoint.
So you don't see my screen now? You don't see them? That's weird.
احنا شايفين مايكروسوفت باوربوينت بس. ما في بيبر حضرتك حطها ولا حاجة ولا لا؟
Yeah, في. Okay, let me. Yeah, so maybe because I opened this through the university itself, so sometimes, like they don't want us to share stuff beyond, so I have to just download it quickly and present it from my desktop. Just give me a second here. But thank you for picking up on this, because I didn't really know that. So file, save a copy. Yeah, sometimes because, like we have a lot of security things here in UPMC. That's why they always like us to do things, like not beyond UPMC. So I'm just going to do this on my desktop and just, like hopefully, and just let me know if you still see everything or not. Okay. Okay. Do you see it now? Are you able to see it now?
No, I think we only see the PowerPoint. So.
Okay. So weird.
دكتور عزة، وحضرتك عملت شير للباوربوينت بس ولا لكل الديسكتوب؟ يعني اصل ممكن تكون ده السبب.
لا أنا I shared كل my screen. Okay, let's do a new share. Okay.
Okay.
And again, let me know if you see everything. Do you see everything now?
You can see presentation, yes, PowerPoint, yeah. Now we can see the desktop, yes.
Do you see it now?
It's okay now.
Yes.
You see the name of the paper?
Yeah, lines and stripes. Yeah.
Correct.
Okay.
Correct. So again, this is a very important paper published in 2007 and talks about important lines, but the lines are mainly in the mediastinum. So the main idea here is to recognize the stuff going on in the mediastinum. I'm still going to use few of these lines and stripes, and mainly, like this line here, which is the line kind of intersect the AP window between the like the bump for the ascending aorta and the bump for the main pulmonary artery. The second line is a paratracheal strip. So this is just the X-ray, shows you the blind spots I'm going to talk about. So number one is usually the apex. Apex is a blind spot, and usually it's very important to make sure that we see the apex like a clear cut, no pleuroparenchymal thickening, no masses coming out of here. And then my second blind spot will be this connection here between the clavicle and the sternum, sternoclavicular joint. The first rib is a blind spot. Sometimes the first rib is totally eroded by a Bankos tumor. Costosternal junction is also a blind spot. The AP window between, like the ascending aorta and main pulmonary artery, the tip of the scapula is a blind spot. And the reason is because it's kind of superimposed density of the tip of the scapula and, whatever the rib is intersecting with it. So our eyes usually, just pick up on this and just let go, because we know it's a little bit dense because it's superimposed of shadow. So if there is a nodule here, maybe we don't see it. The last one is, this actually is, I called this like hilum, not AP window. Hemidiaphragm, the integrity of hemidiaphragm is important. The medial pleural recess and the adjacent to the heart border. And this is my first case. I have many cases, so you have to be a little bit faster. So any resident can take control of this one.
I think they will type in chat box, I think. So.
All right. So okay. So let me see if I see chat. Okay. So what do you guys? Okay. So I didn't receive any comments. So. I can honestly say the findings, but sometimes it's more interesting to get interaction, but honestly I can just go with the findings if this would be more faster, whatever you.
ممكن ينتراكت يا اسلام، يعني ممكن تدخلهم كده اللي حابب.
دكتور هشام مش هيبقى سريع والله، هم يطيب.
طيب خلاص خليني انا present the findings, but يعني I really want you guys to get used to this by, I just want you to get engaged. So basically this is x-rays. All our x-rays are ICU cases. So you're not going to see like a clear PA view. Most of them are portable cases, horrible cases. That's why you have to imagine and, use your imagination a little bit. So if I show you this x-ray and I tell you, identify the finding, everyone is able to see this, hilar mass and maybe, a mass or collapse here and small ex-vacuum pneumothorax at the base. But I want you to pay attention to the epices and tell me what you think here. Do you think something is in here and here? So apparently there is nodular shadow here and there is nodular shadow. And again, the most important part is to compare the density and symmetry. So sometimes we use this technique, which is, invert the x-rays to be able to see the black. Our eyes see the black better than the white. So again, we see a little bit of density here and here. The mass is obvious. And again, the collapse or underlying mass and ex-vacuum pneumothorax at the lung base, right lung base. So this is a CT correlates and apparently shows like a speculated mass here was like superimposed on the first strip. And this was the hilar mass, which was in the superior segment of left lower lobe. And, again, x-rays showed this, but if we don't pay attention, we can just name this one and no one would comment on this one or this small thing here. So this is a second case. I want to hide this because, okay. So this is a companion case, again, shows you how the apex is very important. We can just follow this line here and see if we follow it here, there is like opacity in here. And when we do this inversion, we would see it superimposed on the first strip. The first strip is still intact. It's not eroded, but definitely there is something is going on here. And again, this is, this is I didn't include the CT for the other one, but this is another case. Again, first strip here. So someone may recognize some abnormality here. This is sometimes hard for all of us because no one can tell if this is just the ossification in the first conchochondral junction or there is underlying nodule. So honestly, if I'm reading this x-rays, I would definitely comment on this one and question something on this one, because anyways, I'm getting the CT, but this is definitely abnormality here. And it's likely, like a large nodule. It's not like 0.6 that we can, like neglect it or say like get like a year. This is like above, like 0.8. And this was like while they're doing the biopsy for this nodule, it was definitely a cancer. All right, same theme here. Another, apical, the apex here is okay. The apex here is totally gone. But what else is gone here? So I don't know if you guys follow the first strip here. There is no first strip here. So the first strip is totally eroded. And this is a case of Bancroft tumor or superior sulcus tumor, where there is like it's usually a squamous cell. And it just leads to, like erosion of the first strip, the entire first strip, and usually in case the subclavian artery. So this was a Bancroft tumor, locally aggressive tumor, but it, like I've seen cases missed on total erosion, was missed on X-ray, total erosion of the first strip, because Bancroft tumor is a very aggressive, but locally, so can stay for like a year or something without being big. So if we can detect the first strip erosion, like as early as we can, it's definitely, it makes a different, like a big difference. So our first spot is, again, the first strip, and we rely on the density, the integrity of the first strip, and of course, the symmetry, okay? Okay, this is the second blind spot. And, like, again, this was just a case, like our patients here in Pittsburgh, it's just like it's known for being, most of the patients are so obese. So excuse me for the bad body habitus. Many of them, they would have this, like appearance of a chest. It's not a clean chest x-rays. But again, I want you again to pay attention to this area here and see the difference. It's all about symmetry. So this is a trachea. This is a paratracheal strip. It shouldn't exceed 0.4 millimeter. On either side, of course, like usually we comment on the right side being, like a clean cut, and the left side, sometimes it's hard for us to exclude if it's just a vascular thing or it's real lesion. But once I start to see, like the density goes into, like it's in the lung, it's even, like not like a small tumor. So it just, again, it's abnormality. It's sometimes erode part of the first strip, sometimes not. And I'm not talking about, like incidental finding like pleural effusion or a little bit of, like we don't see the first, like the left lower lobe here. I'm just talking about the main thing here, but I know she has a lot of abnormalities here. Okay. So this was a CT correlation. Again, there is a speculated mass and can just be seen on the x-rays. But the thing is, sometimes here we go with x-rays, and if it's negative, we don't scan the case. Like not in Egypt. I know in Egypt, everyone can go for CTs, but not in here. Here, we kind of still follow the x-rays, and we depend on it. If there is, like it's negative, that's it. The patient can go. Again, this is maybe the same case, just to show you how, like the inversion technique can give you, like a better demonstration of any focal lesion, because again, the eyes see black more than white. This actually, yeah, I think it was the same case. So yeah, and just in a different projection. All right, so let's see. Sometimes I even, because it's very subtle, I can't even see where it is. Let's see. Okay, so I think there is abnormality here because this area here is kind of, like the paratracheal strip is enlarged here. And again, I can't see the, like the apex here. So again, this presentation, I did not do any practicing on it. So I may miss something here. I want you really, if you see something I didn't see, to tell me, but apparently there is abnormality here. Let's see the CT.
There is eroded left clavicle.
The clavicle, are you talking about this area here?
Yes.
Might be, but the lucency is mainly lung, which is normal, but I'm not sure about this area. It may have something here, but mainly the finding is in here because, like this is a lot of densities here. Again, our main reference would be like 0.4, 0.5. All of this is just abnormal, but there may be a little bit of also, like extension into this left side. Let's see the CT. So again, the CT was really infiltrative malignancy surrounding, like the main stem bronchus and, like the mediastinum, but mainly the finding we saw was a little bit in, like in the upper level. a companion case is very similar to the last one. This is honestly my toughest part when I read chest X-ray in a portable case, because many times obese people would have like a lot of fat in the superior mediastinum, and the SVC will be kind of engorged and can give this appearance. But honestly, sometimes I only rely on the density. If I think it's very dense, like this one here, and again, this is the calcification in the distal arch, right? So this is a calcification in the distal arch, the first pump here. And then the second pump is for the main pulmonary artery, but there is a third pump here. So there is abnormality, definitely. So if I'm going to say, okay, this patient is kind of oblique, this could be all just vascular enlargement in the SPC, how can I explain this part here? So apparently there is something, but probably including the entire superior mediastinum. And this was it on CT. So apparently this was the other pump we said above, like the calcification in the distal arch. So this was just adenopathy and infiltrative malignancy in here, and this is just the inversion of it, okay? Okay, so this is another companion case, and again, there is abnormality in here, just density. We look for symmetry. So this is, again, the distal aortic arch, and this is the pump for the main pulmonary artery, AP window, and then when we go here, there is like some sort of, like if I'm dictating this one, I would say that it could be just an adenopathy or something. It doesn't have to be like a lung cancer, but I would question abnormality in this area clearly. But I honestly, if a young age, I would just call it like adenopathy or something. And it was a mass. Actually, this case, if I remember correctly, yeah, I remember this case, because if you can take a look here, there is like a surgical stable line. So this patient have had like a resection of a nodule or something. You can see it like not very clear here, but there is like small stable line, suture line here. And then he had a recurrence at the site of the stable line. That's why it was just a recurrence. Okay, and this is just the pneumothorax because it was like they were like doing a biopsy for him. All right, so this is a case. He was young, 26 years old. I'm sorry I couldn't find the CT for this one, but this case was read as normal. I just included this to show you how sometimes a big finding, this guy had like a posterior mediastinal tumor. It was like a benign tumor. I don't know, schwannoma, some sort of benign posterior mediastinal lesion. But just because it's very well circumscribed, no one called on this one. And the patient stayed for like a year or 2 years without, like anyone seeing this until they got the CT. But in retrospective, you can clearly see there is abnormal. What is this thing here? Again, just follow the anatomy. Younger age groups, they just shouldn't have like a, like any, even the descending aorta usually is not that bulky. So this has to be abnormality. And this was a, like inversion. I just didn't include the CT for this guy. Okay, so this is, I'm sorry, I'm not seeing the history because honestly, like the history is just like cough or very, very, like a common, something is not really like relevant with the finding. So this is again, chest X-ray, and like any of the residents can easily miss this one. And I want you just to pay attention to this area here and this area. So this one is, yeah, that's the first rib, but really the finding I want you to pay attention here is not the first rib itself. It's actually between two ribs, because it's easy to call nothing in here, but between two ribs, there is something here and there is another thing here. And this is just to show you again, the inversion, that's my favorite, how it can show things, like clear more than the other one. So it has actually also nodular mass. This one, I didn't comment on the hilum, but the hilum was also abnormal. But the patient was a little bit rotated. So apparently there was like a dominant mass here and smaller, maybe synchronous mass and hilar adenopathy. All right, so again, blind spots 2 and 3 was just, external clavicular joint and first costosternal joint. And again, we rely on density, symmetry, and also pay attention to the paratracheal strip. All right, so this is a 26-year-old man. This actually patient just came to the ER. I read this case and I was just fast and I did not even see the finding, but I prelimed it because I was watching something else. And then I came back to this X-ray and was shocked. Because this patient was taken to the OR to evacuate brain abscess. So he came with seizure. like, again, I just want you to pay attention to this area. So, like any patient with brain problem, chest X-ray is important to exclude underlying cancer, number one, because, like lung cancer loves to send mets to the brain, but not in 26 years old. So I called the surgeon. He was just on the OR. I said, this patient has a lesion in his chest and it could be cancer, but he's young. And then he told me when we opened it, it was just like a purulent abscess. It wasn't even like a necrotic tissue or anything. It looks like infection to me. Anyways, I told him, get the CT, and we got the CT on him, and this was the CT. Speculated lesion, and just because, again, the scapula, the tip of the scapula is dense. Anyway, it's dense, so we can easily overlook something in here. So it was bad because, like for my dictation, I said, okay, this case, like all the radiologic findings tells me that's cancer, but he had a finding here, which is this, like calcification. And I said it could be granulomatous disease or any sort of atypical infection just because he had a remote sort of fungal infection or any type of, like granulomatous infection. And this could also be some sort of granulomatous thing, even though it really looks like a cancer on X-rays, but not expected to happen in 26 years old. Anyways, yeah, this guy, it turned it not to be cancer. This was the follow-up, actually, and it was like a little bit shrunken in size. Yeah, it wasn't cancer. They did the biopsy and it wasn't cancer, but he was fortunate not to be a cancer. All right, so another case, just also focus on this area here. There is abnormality here, but this is actually turned not to be anything, but this here, which is, like a little bit rounded here. I don't know if you guys see this contour here. And I did this inversion thing just to make it a little bit stance for you. And this was it, hidden in, and just the tip of the scapula. This guy was like also younger age. He was like 30 or something. He had a history of germ cell tumor. And sometimes if the cancer stays stable for like, like few years, according to the guidance, they start to switch to X-rays because they are not expecting him to have mets after, like many years. Anyway, we saw this nodule here. It's very, very tiny. And, like we said, it's unlikely to be a nipple shadow or anything because we can see it here superimposed on the spine. And, again, this is a CT. Actually, we're still following up this one to see if it's really mets or not. I'm hoping it's just like an intraparenchymal lymph node or something, just because it doesn't look like a cancer. But again, it was good pickup. Because anyone that's a germ cell tumor, we don't want this to be, like to develop like a mets everywhere. But again, the clue here, that's not like a nipple, it's too high for nipple shadow anyway, but the superimposed shadow is also seen on the lateral. Okay, so the blind spot number 4 was tip of the scapula. And again, it's because the scapula is kind of thick and it's superimposed on 2 ribs and the tip of the scapula. All right, so this is a case, was it just in the ER, like they scan them for the ER for just like a congestive heart failure or something. And again, if we tell them there is volume overload versus, like acute exacerbation of CHF, they would just give them Lasix and let them go. But there was something here on this case. I don't know if you guys can imagine it or not. It's very subtle, but it's, yeah. With this, like congestive, like changes and engorgement in her pulmonary vessels. This is the CT. There's a speculated lesion in the right middle lobe. Yeah. So again, focusing again on the heart border, I just want you to appreciate if any abnormality here, nothing in here. First rib is fine. Paratracheal tip is fine. And then there is some sort of abnormality here. Okay, that's part of the hilum. Yeah, but this is the hilum. What is this thing here? So it's a subtle finding, but again, it's just, like this is the right heart border. Something is just superimposed on the right heart border and it's beyond the hilum. So the CT showed this metastatic lesion in the spine. And then just this part here. Yeah, this case actually was very nice because I read it with my resident. And this X-ray was done like a month before. So this one was a month earlier. And we saw this thing here, And then the resident, like I was suspicious from the beginning about this case, but just I didn't want to play it so, like so hard. And I said, okay, let's just dictate it as, like he was like coming with, I can't remember, maybe pre-op or something. It wasn't really like something we would make a big deal about it. But I said, okay, it looks like some sort of scarring or underlying something maybe present. Let's bring him back for like a repeat. And then he came like 4 weeks ago, 4 weeks after the first one. And then apparently there was a mass at this point. Like we see fullness in here, but in here was just like a really cystic changes and then scar surrounding it. That's why, I didn't make a big deal of it, but this is the CT. So especially in patients, in smokers in general, there is this special variant of lung cancer. It's called pericystic adenocarcinoma. So whenever you see a cluster of cyst or a septated bulla in a chest on a CT, or of course on X-ray too, and you start to see any nodularity, that's definitely can be an early, stage of pericystic adenocarcinoma, which usually, kind of grow on top of cystic, parenchymal cystic changes, which can be a complication from emphysema. So this one, I just sent him for like biopsy, or I'm 100% sure it's cancer, but yeah. Another case, also companion case of the heart border. So this is the hilum here, this is the hilum, and there is this thing here, which we can easily, okay, that there is a branch here, so it could be just vascular, but we did the CT, and this was the CT for him. Just like a speculated lesion, and it was this guy here. Very subtle, but sometimes, honestly, we have to raise our, suspicious if it's really looks like not, at least like sometimes, honestly, if I'm thinking that's maybe not just atelectasis, I'm not going to scan every case for a CT, call him back for a CT, I would just ask at least for 4 weeks follow-up to make sure, the finding is real or not. But again, we read a lot of x-rays, like we can't send everyone for CT, but many of them, when we make the call, there is underlying badness, especially, many of the people are just a smoker. So again, the blind spot, the last one was just a heart border, which is just follow the contour of the right heart border and left heart border. Okay, this guy, she was young, she was relatively young in this case, and I just want you again to follow the blind spots here, there, first strip is intact, and then the heart border in here is okay, and then the heart border, and then the hilum. So there is something here. The patient is rotated. Sometimes, being not in a, sometimes we overcall, we don't call stuff just being, position or something. But I always rely on the fact is that if you think the density is a little bit high, if you think there is like a shaggy border, it's not like a clean border. I mean, main pulmonary artery should be in here. So what is this thing here? There is something else is going on. Younger people can have a little bit higher distal aortic arch. So this patient, because she's tall, especially here, you can see them a little bit higher aortic arch. Like you see this aortic arch reaches to the clavicle. And then the second pump here is probably the main pulmonary artery, and the AP window is filled with something. And this was like, again, suprahilar mass on the left side. Another companion case was again, same abnormality. Just follow the contour of the aorta. This is the descending aorta, and there is something going beyond it here. And this was the CT correlation for this one. This guy had also abnormality in this hilum. Again, look for density for the hilum. It's very dense. It's very irregular. I mean, if I have a history for this guy and they told me this patient have had a history of lung cancer, I would just dictate this one as post-radiation fibrosis. But if there is no, like the first thing I would check on a case like this one, if there is any history of post-radiation fibrosis, because there is a lot of tractions here, and like it looks really, really like cicatricial. But if no history of lung cancer or any radiation, I would call this like infiltrative malignancy on this side. And there is also, like some sort of adenopathy on the left side, because there is fullness in here too. Please, if you want to stop and ask me any question, like don't hesitate to stop me, okay? Because, all right. So this one I think was the one I just presented. Okay. Another companion case, again, hilar mass here. And Okay, so this case was not a cancer. This case was just like, I put this one just to show you that, like sometimes if a patient has a history, like this was just a cabbage case and he came for like chest pain or something, but he had like a history of surgery like a month ago or 2 months ago, and it was like open heart surgery. And then we saw this, like abnormality. So the first thing we would think of this one is it like anterior-mediastinal mass, posterior-mediastinal mass, or, like we rely on the hilum overlay sign. We can definitely see it. So it's probably not in the hilum, either anterior or posterior. So this one, we see the AP window line. So I would just call this as anterior. But also because of the descending aorta and recent surgery, I would also be scared of any dissection. Anyway, this one was actually post-surgical hematoma, but it was just nice to include it because we're talking about this area here. So I just included this just like a differential case. And this is again, hilar mass and the infiltration here. And hilar mass and lymphangitic carcinomatosis. In this lymph. I mean, if again on chest X-ray, sometimes we are okay to call, like if we think that the increased reticulation is too, like extensive, and like we see clearly mass, I can just describe this as a hilar mass and increased interstitial reticulation. It looks like could be lymphangitic carcinomatosis. But again, many of the patients have just a bad heart functions, and you can easily see a little bit of cardiogenic edema superimposed. But just the asymmetry makes me feel that there is something is more than just a hilar mass. Okay, I think this was it. Yeah, she was like, it's infiltrative malignancies. This is the MIP from the PET, and this is a mass. And she has a little bit of interstitial pulmonary fibrosis also. I don't, okay, so
could you please again show the X-ray of this one?
I think, yeah, this is the X-ray here.
Thank you, thank you.
Sure. Do you have a question?
I just forgot what X-ray looked like after seeing that mass. Yeah, thank you.
Of course. Yeah, I was just like, again, a hilar mass. So hilum and perihilar, it's very important for any hilum. Just compare both hyla, and also symmetry. So when we comment on the hyla, actually, we should comment on 4 things: the density of both hyla, the symmetry. We know that sometimes, not sometimes, most of the time, the left would be a little bit higher, but at least, like make sure that it's not like kind of, like too high or too low. And also, like if the outline is just a regular outline and vascular outline, and of course is a size if there is a mass or something. Okay, so this is a gentleman. He was young, 40 years old, and I just don't know if you guys can see the abnormality here. It's a huge abnormality, huge. And this case was just a bad case because it was missed. And the reason it was missed is, again, we see tons of cases with diaphragmatic elevation. And I always teach my residents that diaphragmatic elevation will look for this medial pleural recess here. It should have lung. So if it's the difference between eventration versus paralysis is actually the insertion of the kind of origin of the diaphragm. So if it's just eventration, we still should see the diaphragmatic slip down here, and then the lung will kind of protrude or herniate into this, like junction between the diaphragm. So we should still see angle of air in here. That's diaphragmatic elevation. So if we, eventration. So if we don't see this, there is a chance it's either pulmonary underlying pneumonia or underlying effusion, or there is a mass or something. So this one was not like, people just call this like diaphragmatic elevation, but there is actually still, we can still see the diaphragm here. And this was just a huge sarcoma. So again, it's just sometimes he also had like a little bit of hernia here, and the stomach was herniating. But that's why it was a little bit confused. Many people was confused about this case. But just to show you how sometimes, like if you see the diaphragm is still there here. And there is some sort of density here. Yes, focal diaphragmatic elevation can happen. Yes, like focal herniation in the diaphragm, focal defect in the diaphragm can happen. And then you can have like kind of, prolapse of the intra-abdominal fat into the chest. But if it's that large, at least ask for lateral or ask for CT. And again, it was just like a bad sarcoma. another companion case. This one is easier because definitely you can see a defined, like edges. From the density, I may have called this just like a cyst because it's very dense. But this one actually turned out to be also malignancy. Maybe it was like a fibrous pleura, fibrous tumor of the pleura. But again, this is, no one would miss this one, but it's just to show you that the fact is that big portion of the lung is still behind the diaphragm. Like it ends here, the lung ends here. So anything here can be still in the lung. Don't think that lungs already ended. It's still there behind, like kind of behind the diaphragm. Okay, so this is also very subtle finding. I'll give you a few seconds. If someone can see the abnormality, it would be great on this one. And again, we're focusing on the hemidiaphragm now. Can you see it? So hopefully someone can see this little nodule here. And it's this guy here. She was young. She was like, I can't remember, 40 years. My history is all hidden by the screen down here, so I can't really see the history. But I remember she was young. And again, clearly there is nodule here and there is nodule here. So we got the CT, and the CT actually showed this nodule. So we asked for the PET. It was non-FDG avid. So when you see a nodule like 1 cm and non-FDG avid, it doesn't stop at this point because it is neuroendocrine tumor. It's usually, if it's well differentiated, KI 67, 25 or 30 and below, it will not take FDG. If it takes FDG, by definition, it's not a benign anymore. It's dedifferentiated neuroendocrine tumor. So in order for us to comment on this one, we have to get something called dotatate, which is a special radiotracer for neuroendocrine tumor. And this one was dotatate avid, and it was carcinoid, and they removed this one. They removed the nodule. It was consistent with benign carcinoid. KI 67 was 5 or something. So again, this was the hemidiaphragm sign. And again, look for the thoracoabdominal sign. If something, like goes from the chest into the abdomen, make sure if it's really mass or just the diaphragm, just look for the, like the definition of the, between the diaphragm to separate whatever is in chest from the abdomen. All right. So what is this one? Again, it's just embarrassing. Sometimes I don't really see the abnormality. Okay, yeah. So there is some abnormality here, small nodule or something. And again, this is a type of a lesion which is very, very hard. Most of the time, we would just let go on this one as, like it's like, just like maybe atelectasis or something. But honestly, if I see it like well-defined like that, I would just ask for CT, or at least, like a repeat X-ray and see how it looks on the lateral. And this was the CT, was like a mass. And so my blind spot here is actually this line here. So I don't know if you guys see the, like the medial pleural line here, and here it should contain air. So just when you check on this part here, if there is abnormality, you will see it. But if you don't care to check this one, you can miss this nodule here. All right, so another case, also this line here. This one is hard because she kept her bra on. That's why we see like a skin fold contains the air, which is, again, something we see it all the time here. The patients, sometimes they don't want to, like get like ready for the x-rays. And then we see a lot of skin fold contains air. So it's a little bit confusing, but apparently there is like a nodule here. And, like it's this guy here. This is, yeah, this case, this case actually was very nice because, again, it was a confusing, like I got confused from this case because of this skin fold. Because again, if we follow this line here, it's not very obvious, but she had a total collapse of her left lower lobe. Like, again, it was not called appropriately because of the skin fold. But on the, like when we got this inversion thing, you can clearly see this entire left lower lobe is just collapsed. And there is like a mass in here. And this is the CT. This is the primary. And there was like a additional endobronchial mass here, and has, like occluded the entire left lower lobe bronchus and leads to collapse of the left lower lobe. Okay. So again, this is a medial pleural recess. Yeah, this is just, like it's again, it's not a cancer case, We sometimes do this dual energy technique when we do a subtraction, get like two different, I'm not sure if you have it in Egypt or not, the dual energy technique. So we can get like two different factors, one for the soft tissue and then one for the regular chest X-ray 80 and 120, and they kind of subtract them to get the bone. And this one would be the soft tissue. So there is some abnormality in here, which is this guy here. And on the lateral, you can see very, very, like faint opacity here overlies the spine. And this was the CT. It was just a pneumonia, but honestly, we called this one as a mass. But the CT was really just a pneumonia and disappeared after that. But just because it was nodular. This case was a lung cancer screening, and it was very, very, very interesting case. I called this one, like I saw this lesion here in the right middle loop, and it looks just like a consolidation in the right middle loop. So I said, this is pneumonia. I tried to reach out with the physician to see the history, if the patient has a fever, or because this is a bad pneumonia, and it looks like a lobar bacterial pneumonia. Anyway, he did not respond to me. And then I said in my dictation, this is, for me, I need, it might be like aggressive malignancy, but radiologically, it looks like a pneumonia to me, classic bacterial pneumonia in the right middle loop, but underlying malignancy cannot be excluded, and just bring the patient back, after 4 weeks in the presence of symptoms of pneumonia. If there's fever, the patient looks toxic or whatever. He did not respond, and the patient came after 4 weeks, and it was a type of lymphoma, Molt lymphoma. It was bad because when we repeated the chest X-ray, the abnormality was still there. So I said, that's not a pneumonia. And then he called me and he said, no, she didn't have any fever. So I said, that's malignancy, maybe, like some sort of adeno, or I really didn't include at this point any lymphoma. I just said maybe, like a bronchoalveolar carcinoma. She was like 60 or something. But then when they did the biopsy, it was like a Molt lymphoma. But just something to keep in your mind, that Molt lymphoma can simulate bacterial pneumonia. And of course, any bronchoalveolar carcinoma can look very infiltrative too. All right, so this case is, let me think. Yeah, this is one of the cases that I see. That's how it's hard, chest X-rays for us. I think there is maybe if I'm reading this one, I would say maybe there is a lobar collapse in here, because this area here looks very, very, the aeration is not that good in here. But apparently I put it for a different reason here. Yeah, this is one of the cases I really can't remember. Oh, oops. Yeah, maybe this one was wrongly put because it looks like it was my last case, the last one. That's it. Those are my kids. I kind of finished early. I really was, expecting this to be more of interactive, but me presenting everything, I kind of finished faster than I would expected myself to do. Do you guys have any questions for me?
Thank you very much, Dr. Azza, for these interesting cases. And these are very challenging to read plain chest X-ray carefully. Also, abnormal positions make differences or make difficult to read the chest X-ray properly. So this is another issue that we can't or some lesions can be overlooked on chest X-ray. So this is a very important picture to look for all these hidden areas in the chest. There are many hidden areas on the chest, as you mentioned now, that we must look for on reading plain X-ray of the chest. Thank you very much, Dr. Azza.
Thank you. And please, if any one of the residents needs to ask me anything, again, I was expecting this to be interactive. That's why it was kind of, I finished earlier, but please, if any question, do you guys have any question for me, the residents, if they are interested in asking?
One question from the chat box: how can you differentiate between fibrotic nodule and mass with cystic disease?
Honestly, like I have to be honest. This is very, very tough on X-rays, but of course on CT, yes, you can differentiate, because again, the default is if you see a septated bulla or, like a cluster of small cysts, especially a patient with emphysema or underlying, like smoking history. Once you see any nodularity along the wall of this septated thing, just call it as, again, adenocarcinoma. I have a good paper, actually. I don't know, I can share it with Islam if he can share it with all of you. It just, like from radiographics talks about this type of malignancy, which is pericystic adenocarcinoma. Just call it as a real cancer. And then if they biopsy it and it turned not to be like a, like a cancer, that's okay. You don't want to miss cancer. And the thing about this is any septated bulla or any, like a cluster of cystic changes in emphysema, that's actually a site for, like a precursor for like a development of a cancer or something. So what happened is it will start to develop like just a ground glass opacities. This is when we call it like in situ or something. Once you start to see a nodule, that's by definition, it's no longer in situ, it's invasive. So if it's invasive, it needs to be taken out, just like the case I included. It was invasive. I'm telling you, that's already speculated. That's invasive. That's no longer like a low-grade adenocarcinoma. And this is when it can metastasize and go anywhere. So honestly, sometimes if I see cystic cluster of disfigured cysts with a little bit of architectural distortion in small area, I would just measure this septated bulla or cluster of, like abnormal cysts. I would just give like a follow-up. I mean, the guidance, honestly, like, like when we do lung cancer screening or even Fleischner, we don't put a lot of, like focusing on this type of cancer, and that's a defect on the follow-up for Fleischner. I know we have lots of holes still in like the follow-up of lung lesions, but this sometimes just come with experience. When I see a cystic lesion, I don't feel it's okay, and I see a little bit of ground glass opacity, I start to give like a follow-up without even having a guidance on the Society of Thoracic Imaging. Any other questions?
Yes, I think one is asking about the lung cancer. What's the guideline for follow-up? Do you use just X-ray or CT?
Lung cancer screening, if we see like a lesion on lung cancer screening, the guidance has to be also done with low energy lung cancer screening. So basically, lung cancer screening is a technique when we give just a very, very low energy. So if you read the CTD value for lung cancer screening, it has to be below 3 milligray. If it's above 3 milligray, we actually have to tell them that there is abnormality here, and this has to be like a QC problem because it should be kept very low energy. So when we see a lesion, we start to give it whatever, like the lung cancer screening we have from, like up to like 4B or 4X or whatever, depends on the category. We start to ask them to come back, starting from like, if we see like a nodule from 6 to 8, we give it like a 6 months follow-up. Any follow-up for abnormality coming from a lung cancer screening has to be also done with low energy lung cancer screening CT. So also the low energy one, which is like, again, has to be kept like around 3 milligray or something CTD value.
Okay, so next question. Someone is asking about the last case, about the consolidation ones that turned out to be lymphoma. What's your next step if you don't have the clinical history? I think the clinical history was critical for this case, but what was your next step if you don't have the clinical history?
I remember when I dictated this case, I just gave it like lung grade 0, but I actually fault myself after that. Fault myself because when I give it 0, I said, okay, that's incomplete because portion of the lung is hidden by pneumonia. But after that, like again, everyone is okay to make mistakes. I said in the next time, if I see a case like this one and I don't have a clinical history, I'm just going to give it like 4X, like very suspicious, very suspicious. I'm not going to rely on the fact that maybe pneumonia. It could be, like, yes, I said like incomplete, give it 0, bring the patient back after 4 weeks for, like a follow-up with X-ray. That's exactly what I said. I said, bring the patient back after 4 weeks for follow-up. And, like if the symptoms of pneumonia disappeared and resolution of this finding, I'll, like grade this case as lung cancer screening too. But when the patient came after the 4 weeks, it was very, very similar to the first one. So I said, that's cancer, especially she didn't have any complaint. And, but again, if you see something like this in a lung cancer screening, just give it 4x. Very, very suspicious for lung cancer until proven otherwise, especially if you don't have any clinical. But if you have clinical saying that this patient has fever, that's pneumonia, but it's very unlikely, again, I called this patient, I even included in my dictation that this, ordering physician, I made several trials to reach out with him to know if the patient has pneumonia or not. Clinically, he did not respond. That's why he was so scared when this turned to be cancer and he was trying to call me everywhere. I didn't see your text. Yeah, but what am I supposed to do? We read tons of those, and we have to be if you don't get back to me, I have to dictate it like pneumonia until I see the patient. But again, it was a mistake. Next time, if I face any case like this one, even though pneumonia is 95% of the cases, I would still call it like 4x, very, very suspicious for lung cancer until proven otherwise.
Okay, so next question. Thank you for the talk. The question is about the multiple lymphoma case, how to differentiate multiple lymphoma from neuroendocrine tumors or primary adenocarcinoma.
All right, so neuroendocrine tumor is different, is a very, very different entity, because again, carcinoid, it depends on, carcinoid usually is a benign tumor, right? So it's not going to be, again, when we do the CT, if it's with contrast, it will be enhancing. Usually carcinoid occurs along the airways. So it will be like central in the trachea or will lead to total obstruction of one of the airways. But the one we see, and like the one I presented to you, was the parenchymal type of carcinoid. This is not a common one. This is rare. So when we see like a lesion, and I don't know, guys, if you know about the DIPNETCH or not, but DIPNETCH is a precursor of a carcinoid. So sometimes we see tons of nodule in the lung, and they all have like a peripheral distribution. Sometimes they have also mosaicism with them. So this is like a precursor of neuroendocrine tumor. If we see dominant nodule, or if we see only one nodule in a young patient, and we don't know what is this, just, consider this, it could be a precursor for carcinoid. Bring her back for a follow-up. And you can also give contrast, because most of the time we do this without. If it's enhancing, just to recommend PET-CT. Again, the PET-CT usually done with FDG. It will be non-FDG. Doesn't stop here. You have to ask for the special radiotracer, which is the dotatate. If you don't have this in Egypt, biopsy. And if it's carcinoid, it has to be taken out. That's for carcinoid. Adenocarcinoma is, something, it depends on the age. Sometimes it's mainly like carcinoid, benign carcinoid occurs in younger age. If it's the aggressive form of carcinoid, it will be all over the place. It will not be only in airways or parenchymal type. And usually it has a lot of, involvement of, the bone, and usually classically gives this osteoplastic type of bone cancer. But neuroendocrine tumor, if it's the aggressive form, it's hard to differentiate based on the imaging. Adenocarcinoma, it depends. If it's if it's like the type which is local, the one can simulate the multiple lymphoma I presented. This is sometimes I call it, if I see a patient, for example, I call it first pneumonia, and then we scan the patient after 2 months and it's still present. I wouldn't still see pneumonia after 2 months. Yes, sometimes there is a lag in the imaging compared to the clinical picture. Like sometimes a patient is totally cured from the pneumonia, but we still see abnormality in x-rays, but we still have to see some improvement. If you don't see any improvement on CTs or x-rays after like 2 months or 3 months of like a consolidation in the lungs, call this cancer, because it shouldn't stay that long. That's the main point here, how long you've been following this up. If it's like unless it's the atypical type of pneumonia, which maybe is eosinophilic pneumonia or, organizing pneumonia, all of this can be in the differential, but at certain point we have to biopsy. We can just say it's nothing. It should be worked up. Multiple lymphoma is not something common to happen, but it's just I included this one because it's very rare. It's very, very rare. This was my first time actually to see multiple lymphoma. That's why I included this one. So it's not a finding we would see all the time. Lymphoma usually in the lungs primary lymphoma in the lung is not something common I see. It's usually, like the secondary type of lymphoma when you see lymphadenopathy, and lately it can infiltrate the lungs. Or sometimes if there is underlying Sjogren's syndrome, LIP, this can also be a precursor for a frank lymphoma in the lung, but it will start with lymphocytic interstitial pneumonia on top of Sjogren's disease, and then later on would get lymphoma. Okay?
Yes. Okay.
Dr. Azza, about this case, if we saw an area suspected to be consolidation, and finally the final diagnosis will be lymphoma or carcinoma or whatever, can a contrast injection help in these cases, or can differentiate between consolidation and neoplastic lesion?
Pneumonia should not enhance. So pneumonia by definition shouldn't enhance because that's inflammation. It shouldn't take any enhancement. That's actually a good point for me because sometimes, you know, like a case coming from a ER was cardiac arrest, and then she aspirated, and you know, like this aspiration is enhancing. I tell them, okay, that's just aspiration. She aspirated. That's why we still see enhancement. But if this is a patient actually with pneumonia before she came in, usually pneumonia shouldn't take any enhancement. It should not. Any malignancy can take enhancement, definitely, either lymphoma or cancer, you know, like adenocarcinoma. But adenocarcinoma, it depends on the type. Like, for example, mucinous adenocarcinoma, lipidic adenocarcinoma, those are all just like mucin. The lipidic form has fat, so they will not take a lot of enhancement. So I cannot rely on enhancement. Lung cancers have so many variants. And honestly, for us, especially, we see a lot of population of smokers. We see a lot of this lipidic form, which looks like a lipoid, you know, like lipoid pneumonia, just a fat density. And also the one I showed, the pericystic one. Again, the classic adenocarcinoma, which is like, I mean, the bronchoalveolar carcinoma, it's just like an area of consolidation, no more than that. So again, my main thing is I give it follow-up, and if it stays for like long time, we will just raise the possibility for cancer, especially we don't know since when this consolidation showed up. Sometimes we're lucky to see like older imaging, and then it's a new thing, like just like 2 months ago, no cancer will develop that aggressive in 2 months. So we would say, okay, that's probably pneumonia. But again, follow-up is a key. But enhancement, I don't think so. Just to differentiate pneumonia from non-pneumonia. Pneumonia, I would say, you know, like if it's non-enhancing at all, it could be more pneumonia, with exception of the variants. We spoke about the lipidic type of adenocarcinoma, or the bronchoalveolar carcinoma, if it's still, you know, like just early or something.
Okay, so I have a question for me, but it's not related to the lecture, okay? So,
No, sure.
okay, so if you have a case with bilateral lower loops fibrosis, and you have some scattered area of GGO, do you call it fibrotic NSIP or UIP?
Sorry, what did you say about the upper lobes? What's GGO?
No, lower lobes. So you have ground glass opacity, some scattered areas of ground glass opacity, and you have the main predominant pattern of this case is fibrosis of lower lobes. Do you call it NSIP or UIP?
By definition, if we see ground glass opacities in a bibasilar distribution, there is something is going on in addition to the UIP. Yes, if it's bibasilar, I see traction bronchiectasis without honeycombing by the guidance of the thoracic imaging, that's called the probable UIP. Because, you know, like the big classification on the thoracic imaging, 3 categories. UIP, probable URP, inconsistent with UIP. So from what you're saying, you're telling me it's a probable UIP. But if I see ground glass opacities, that may tell me that's not a UIP or something else is going on. What is the thing? It could be the active alveolitis, which is a very common finding with UIP. But the main thing really I differentiate NSIP from UIP is a pattern. UIP is a disease mainly from the pleura going inward. So it's juxtapleural. So the key is juxtapleural. However, NSIP is usually immune modulator thing, comes from the vessels. So it will be more centry, you know, like bronchocentric, and then spreads peripheral. That's why sometimes you see sparing in the subpleura. So NSIP, bronchocentric, and then it spreads to the periphery. UIP is some sort of starting from the pleura and going inward. But bibasilar in general is more UIP pattern. But your question is very hard because we all sometimes, you know, like not 100% sure. But honestly, most of the time I just call this UIP. If I see the bibasilar distribution, loss of volume in both lower lobes, traction bronchiectasis, with or without seeing honeycombing, that's probable UIP. Okay, there is also a very common pattern, because I always tell my residents it's very easy in chest to call the pattern, but it's hard to call the underlying etiology. But there is important underlying etiology, which is called combined interstitial pulmonary fibrosis and emphysema. So many times you see actually hyperinflation in the lungs and then fibrosis in the bases, and this occurs with smoking. So they will have like the pattern of centrilobar and paraseptal emphysema in both upper lobes, and then they would develop fibrosis. It starts with NSIP, eventually ends with UIP. Okay.
Yeah, we would like to have you for interstitial lung disease another lecture.
It would be my pleasure. Thank you for inviting me, and it was very, very nice to spend this time with you. And anytime, guys, I would be happy for me to present anything. It's my pleasure.
Okay.
Dr. Azza, excuse me, I have a last question.
Lots of questions. I just, like I'm on cardiac rotation today. I'm constipated reading, but I'm happy to answer any question on email. I'm gonna,
Okay.
If you have a question, I'm happy to answer you now. Just, is it the quick thing?
Okay, it's a quick question. Okay.
Yeah, sure.
Regarding the follow-up of cases in X-ray, like your case, what was expected to be pneumonia. We have the impression generally that rapidly growing tumor, this is generally with malignancy, and stationary and slowly is with benignity. So in the chest, if we have very rapid growing of the tumor, it's considered with benignity. And sometimes they're saying very rapid growing tumor, this is maybe inflammatory changes. طبعا considering the patient clinical condition. So if this is true, what is the threshold for the duration saying it's rapidly enlarged, very rapidly enlarged, not enlarged, like duplication in 1 month, or what is the threshold to consider it? This is not rapidly growing lesion, it's a very rapidly growing lesion, so we consider the inflammation.
I'll be honest with you. What's your name?
Mona.
Honestly, this is a very good question, because, I know most of the pulmonologists rely on this thing very, very much. Honestly, the threshold for us is something, relative, like I would say 4 to 6 weeks. But it's all about measuring the volume, right? Like what we do is, for example, if I see a nodule, okay, and this nodule was 1 cm, I do like volumetric analysis on vitreous, and then I get the volume. If this doubled the volume in, in like short time, which is like, 4 weeks or something, I would raise the possibility this could be inflammatory. But again, it's not like something I would rely a lot on. That's a pulmonology people. It's not me, honestly. I don't rely a lot on this threshold, unless I'm 100% sure he's young. He's, there is a lot of things, going on with him that would make me think that with this very, very rapid, rate of growth, it could be a benign thing. But it depends, we put things together, the radiologic image, the clinical. Clinical is a key always. I always contact them and talk to the clinician, see what's going on before I rely on this. But again, usually the volume, if it doubles within like a period of 4 months or 4 weeks, that's when I start to think, okay, that's a very, very rapid threshold of growth. It could be not malignancy. But you never know. And again, the clinical context is important, because sometimes, for example, a patient with underlying, immune compromised patient, they are very, very liable to get the PLTD. PLTD sometimes grow very fast, right? So how can you tell it's not like he's immune compromised already and he's growing, and that's PLTD? I remember a case was like that, and we said it's inflammation, and it turned it to be PLTD after we gave it like a little bit of, time, like 4 to 6 weeks. That's why
we can't completely rely on this.
No, I don't. Honestly, I don't. I just follow the guidance, the thoracic imaging guidance, and my clinical, perspective, but I don't rely a lot on, but I know all the pulmonologists always, sometimes even we tell them that's bad, they would say still, okay, that's inflammatory. Sometimes they are right, sometimes they are wrong. So, but again, I just follow the guidance for any, like Flashner or whatever. And if it's just like a personal opinion, I just give my opinion, depends on the clinical context.
Thank you. Okay, so
thank you.
دكتور عادة شكرا جزيلا، ونتمنى حضرتك محاضرة انترستيشن لونج ديزيز.
والله ان شاء الله تحت امركم، والله اي وقت اعمل لكم حاضر انترستيشن. انا اساسا كنت مكسوفه النهارده مع الدكتور لايك فيشمان والناس دي، قلت الناس دي هتقدم لهم ارتفيشال انتليجنس وانا جاي اقدم لهم بيزك chest x-rays. But I sent like few topics and this was the one like we decided to do. But I was embarrassed. I said, like, let's present something really the thing we see. But again, x-rays is a challenge for us because we read this in addition to the CTs. That's why we have to do like algorithms so we don't miss stuff and then someone will come and sue us. That's a big deal in USA to be sued for like an audio or something.
Yeah.
That's why I just wanted to introduce this to you.
Yeah. Thank you so much.
But yeah, of course I
Okay.
Thank you. Have a good day. Bye-bye.
Okay, take care. Okay. Dr. Muhammad Toumi. Dr. Muhammad
Toumi.
Yes, hello everybody. Assalamu alaikum.
Dr. Ramesh, can you hear me?
Yes, I can hear you.
All right, thank you. Thank you so much. Dr. Muhammad Toumi, go ahead, please.
Yes, it's thank you for very much for inviting me to be here today, and it's an honor to introduce Dr. Ramesh Iyer, who is an eminent pediatric radiologist at Seattle Children's Hospital at the University of Washington. He's the professor of pediatric radiology, and he also serves as the vice chair of education for the University of Washington Radiology and director of radiology quality improvement at Seattle Children's Hospital. It's an honor to have you today with us, sir, and we are looking forward for your pediatric cases review today.
Thank you so much for having me. It's a pleasure to be here. Thanks so much for inviting me. So I'll be going over some pediatric radiology cases today. Let's see. So the way my talk will be organized will be I'll have 30 image-based multiple choice questions. I just focus on sort of take-home points, and I try to move quickly. I try to focus on the higher yield material for you all. So first case, 3-year-old with a cardiac murmur. What I'm going to do also is I'll just pause here for a few seconds and just have you sort of gather your thoughts. I'll present a multiple choice question. You can sort of keep your thoughts to yourself, but I'll go over the answers in a moment. So here's the first case. Question here is, which of the following features is present? Right aortic arch, pulmonary arterial overcirculation, right ventricular hypertrophy, or cyanosis? So again, I'll just have you just for a moment think about what choice you would go with. And the answer here is pulmonary arterial overcirculation. This is also known as shunt vascularity. As we think about shunts, specific left to right shunts, there's 4 types primarily: atrial ventricular septal defects, atrioventricular septal defect, otherwise known as endocardial cushion defect, or patent ductus arteriosus. So shunt vascularity is a term that we refer to for increased size and number of pulmonary arteries. You may or may not have venous hypertension or pulmonary edema on top of that. These patients are always acyanotic. You can imagine the blood flow increasing to the lungs rather than decreasing. Atrial septal defects, generally older kids and adults, is when it typically presents, especially for small ASDs. I think about A for adolescents and adults. Ventricular septal defects, the most common type of septal defect overall, is in infants. Atrioventricular septal defects we see primarily in kids with Down syndrome or trisomy 21. And then finally, patent ductus arteriosus we see in preterm infants. Ostium secundum defects are the most common type of ASD. Next case, neonate with a flank mass. We've got a nuclear medicine study in the left panel there, and a longitudinal image of the right kidney in the right image there. Question here, which is the following next most appropriate management for this patient? Is it a ureteral reimplantation, nephrectomy, cystoscopy, or pyeloplasty? And the answer here is going to be pyeloplasty. So this is a UPJ, ureteropelvic junction obstruction. It's the most common congenital type of urinary tract obstruction. We typically see on ultrasound pelvic cholelectasis. It's typically the pelvis just upstream of the obstruction is going to be the most dilated portion of the collecting system. You don't see generally ureteral dilatation unless you have reflux as well, vesicoureteral reflux. For functional information to gauge the severity of the obstruction, you can do either you can do a diuretic renal scintigraphy. This is a MAG3 technetium 99M MAG3 study, is what we've shown images of. Or you can do an MR urography. I should mention on the nuclear medicine study, that's a posterior planar image. So the right kidney is going to be on the right aspect of the image. And in those nuclear medicine images, we've got tracer collecting in a patulous collecting system. So the treatment for UPJ is going to be surgical pyeloplasty or surgical revision of the ureteropelvic junction. All right, 7-year-old with new throat pain is going to be case 3. We have a lateral neck radiograph. Question is, which of the following studies should be performed next? CT, ultrasound, decubitus chest X-rays, or an upper GI series? And the appropriate response here is going to be CT. The concern here is going to be for retropharyngeal infection. So on a lateral neck X-ray in kids, you can use an internal comparison is going to be the width of the vertebral body. So from C1 through C3, generally we say those prevertebral soft tissues should be about half of the vertebral body width. And from C4 and below, when you now have the esophagus there, it should be about the width of the vertebral body. So in this case, clearly there's substantial prevertebral soft tissue thickening, more than the width of a vertebral body throughout, from the skull base down. Pitfall here is in kids is going to be pseudo thickening, because a lot of times you have kids that are crying or swallowing and basically have neck flexion, and it can mimic the appearance of prevertebral soft tissue thickening. So you want to make sure that the neck is extended appropriately. CT in this case is going to be needed to look for specifically for either retropharyngeal or peritonsillar abscess. MR is certainly a reasonable alternative if it's available, although for many centers this is not available on the emergent basis. All right, case 4, it's a 1-week-old child with a failure to pass meconium. We've got an abdominal radiograph there on the left image and a lateral image from a contrast enema on the right. So the question here is, which of the following is needed to diagnose this condition? Sweat chloride test, genetic analysis, contrast enema, or rectal biopsy? And the appropriate response here is a bit of a trick question, I suppose, rectal biopsy. So this is Hirschsprung's disease. So this is a functional obstruction when you have absent parasympathetic ganglion cells within the wall of the bowel. You get resultant colonic spasm, and you get a transition point. This is far more common in boys than in girls, and these children generally most commonly present in infancy or in neonatal life as a failure to pass meconium, and you can have in older kids chronic constipation. Typically, this aganglionic segment, it almost always involves the distal rectum and extends proximally and contiguously for a variable period or length of colon. So it's generally a rectosigmoid junction disease. That's about 80% of cases for Hirschsprung disease. So on a contrast enema, generally the rectum should be smaller than the sigmoid. That's the reverse of a normal individual, where the rectum should be bigger than the sigmoid. In some cases, you can have spasmodic contractions of bowel during the enema, and you get these serrated or a sawtooth appearance of the bowel. And then again, you can have a transition point between the spasmodic segment and the more dilated upstream segment. So I mentioned it's a bit of a trick question, because the diagnosis for Hirschsprung's disease is one made by rectal biopsy. This is done frequently by the surgeons. The enema exam, which is what I showed you, is a screening study. It's to refer these patients on for who would be appropriate candidates for rectal biopsy, where the diagnosis is ultimately made. Okay, case number 5. We have a 6-year-old boy with headaches. Sorry, it looks like the word headaches got cut off there, but got an axial non-contrast CT. All right, question here is, which of the following MRI features would most strongly suggest medulloblastoma, diffuse enhancement, cystic degeneration, diffusion restriction, or calcification. All right, and the answer here is going to be diffusion restriction. So medulloblastoma, typically it's a fourth ventricle tumor. Typically it's in midline. It's often uniformly solid. Oftentimes there's not much cystic degeneration. It's a hypercellular tumor. Small round blue cell tumor is what they see pathologically. And it's dense on CT. So similar to meningioma, for example, you have it's a dense cellular tumor, so hyperdense on CT, and it shows diffusion restriction on MR. Frequently we see low ADC values, depending on how the your data is reconstructed or how it is reformatted in terms of ADC values specifically. We usually see less than 800, so very, very restricted diffusion on MR for medulloblastoma. So brief review of posterior fossa tumors in kids. Medullo is a type of PNET or primitive neuroectodermal tumor. Restricted diffusion, it's this hallmark imaging feature, typically occurring midline, and you're looking for leptomeningeal metastatic disease or intradural metastases. Pilocytic astrocytoma. The cyst and the nodule is usually what you see written, either in textbook or article, but actually it's variably solid, and it's oftentimes hemispheric or off midline. Ependymoma, these tend to encroach upon fourth ventricle outflow tracts, so the foramina of Magendie and Luschka. Calcification and cysts are very common with ependymoma. And finally, diffuse midline glioma. This is a high-grade tumor, WHO grade 4. Pregnant pons or expanding the brainstem is oftentimes what it's seen because the pons is the most common location, and it's also the worst prognosis within the brainstem. And it's a histone mutation, so it's a H3K27 mutation. I should mention for any newly diagnosed posterior fossa tumors, it's our standard of care to image the spine, regardless of what we think it is, because we want to make sure to look for metastatic disease, because of course that will adjust the treatment algorithm. All right, case number 6, prior 30-week neonate with dyspnea. We have an AP chest radiograph. Patient's intubated. So which of the following is the next most appropriate therapy? IV antibiotics, surfactant, diuretics, or placement of a chest tube? And the appropriate response here is going to be surfactant. So surfactant deficiency disease is a disease among preterm infants. Diffuse, this sort of granular opacities is the most common appearance. Low lung volumes is what you see, although the lung volumes, of course, change once they become endotracheally intubated. Pleural effusions generally are uncommon with surfactant deficiency as opposed to, let's say, infection. The treatment for surfactant deficiency, not surprisingly, is exogenous surfactant, and that's done typically to the end of tracheal tube. And this may progress to chronic lung disease. Chronic lung disease is I would say, an endpoint for many disorders. Surfactant deficiency being one of them, things like meconium aspiration infection, and we typically see that after about 1 month of age. All right, 2-year-old with a flank mass. We've got a sagittal ultrasound image of the right kidney on the left-hand side of the slide, and on the right-hand side of the slide, we've got a coronal contrast enhanced CT image. So where will this tumor most likely metastasize to? The lungs, marrow, the other kidney, or the peritoneal cavity? And the answer here is going to be the lungs. This, of course, is Wilms tumor. It's the vast majority of all renal tumors in kids. The majority of kids with Wilms tumor present under 5 years of age. It grows like a sphere or a solid ball. It tends to displace rather than encase vessels. The claw sign is what the white arrows show here. This suggests a renal origin. You can use that really for many abdominal parenchyma. The claw sign is not specific to the kidneys, although we most frequently refer to it, the claw sign with the kidneys. Calcification is uncommon in Wilms tumor. It's about 10% of the time, and when it metastasizes, it typically goes to the lungs. All right. 16-year-old with knee pain. We've got AP and lateral radiographs of the knee. Question here is, which of the following characterizes the most likely pathology? Do we see beveled edge involvement of the skull? Small round blue cell histology, usually located around the knee, or pain worse at night relieved by non-steroidal anti-inflammatory drugs? And the answer here is that this type of lesion is usually located around the knee. This, of course, is osteosarcoma. It peaks usually in adolescence to early adulthood. The majority of these tumors occur around the knee. In fact, if I have an aggressive bone tumor in a child around the knee, I'm going to be leading with osteosarcoma almost all the time. On radiographs, it's generally an aggressive tumor. It has a wide transition zone, meaning from normal bone to abnormal bone. That's a relatively wide space. Interrupted or an aggressive type of periosteal elevation. We have these amorphous calcifications. That's calcification of osteoid matrix, tends to be cloud-like in appearance. We do MR for local staging, and we're looking for skip metastases, as what the arrow is pointing out. So looking for mets in the same bone or as well as across the joint. The main differential consideration really is Ewing sarcoma. Between osteosarcoma and Ewing sarcoma, that's about 90% of primary bone tumors, although certainly Langerhans cell histiocytosis can also appear like an aggressive bone lesion. And then if you have multiple bone lesions in a young child, think about metastatic neuroblastoma. Beveled edge appearance is a classic nickname, or a term for Langerhans cell histiocytosis, especially when it involves the skull. And in Langerhans cell histiocytosis, it involves the skull in about half of cases. That small round blue cell histology I mentioned earlier for medulloblastoma is also true of Ewing sarcoma, which has a relatively broad skeletal distribution. It likes flat bones and it likes diaphyses, unlike osteosarcoma. The pain worse at night relieved by NSAID is very typical history for osteoid osteoma. You see a bone tumor, which is a lucinitis. It may or may not be calcified. It typically has a robust host bone response. So you see this sclerosis or this mature periosteal elevation, and the treatment of which is going to be, at least at our center, we like radiofrequency ablation or microwave ablation. Lots of different types of therapies. Of course, this is not an interventional talk, so I won't be getting into that too much. Okay, case number 9, neonate with dyspnea. We've got an AP chest radiograph as well as an axial image from a CT of the chest. Question here is, what's the most likely diagnosis? CPAM, a congenital pulmonary airway malformation, a bronchopulmonary sequestration, bronchiolitis obliterans, or a congenital lobar overinflation. And the answer here will be CLO, or congenital lobar overinflation. So this is a similar pathologic spectrum as bronchial atresia, where you have narrowing and overinflation. You have an occlusion with atresia. It's basically sparing of the lower lobes. So upper lobes and the right middle lobe are going to be the most common sites. It has a one-way valve effect where fluid and air enter a lobe but have difficulty escaping the lobe, so it gets overinflated. On prenatal ultrasound, like any congenital lung lesion, it'll show up as an echogenic pulmonary mass. It's really a lobe that's expanded and it shows up as a mass. So differential considerations, what you're going to be looking for are all the other lung lesions essentially that I mentioned as differential considerations, CPAM, sequestration, and of course, anytime you have a lucent lung, think about pneumothorax. Okay, 7-year-old with altered mental status. We have 2 axial flare images here. What's the most appropriate therapy? Steroids, antibiotics, acyclovir, or anticoagulation? And the appropriate response here is steroids. This is ADEM, or acute disseminated encephalomyelitis. It's immune-mediated, monophasic, acute demyelinating disease. Oftentimes is post-viral. So these kids might present with an upper respiratory infection a couple of weeks prior. It's usually asymmetric, involving white matter, so periventricular or subcortical white matter. You can get deep gray nuclei involvement. These, for example, in the bottom image has thalamic involvement. Excuse me, steroids are going to be treatment of choice for ADEM. Other considerations are going to be your other demyelinating diseases, multiple sclerosis, neuromyelitis optica, or Devick's disease. I think it's SD now, neuromyelitis optica spectrum disorder is the appropriate term there. But other demyelinating diseases are going to be your differential considerations. All right, case 11, 6-month-old with abdominal pain. We have an image from an upper GI series. So which clinical feature is most typical of this condition? Is it a strong male to female ratio? Bilious emesis, trisomy 21 genotype, or current jelly stool? And the answer here is bilious emesis. This, of course, is malrotation. Pathologically, these patients have a short mesenteric attachment, and it increases the risk of midgut volvulus. So malrotation is different than midgut volvulus. Malrotation predisposes one to have midgut volvulus. The classic clinical history here is bilious emesis. This is what we see in the emergency department all the time. An upper GI series is going to be your standard study. Some places do ultrasound for this. When you do upper GI, you want to make sure that ligament trite is meeting 2 criteria on an AP. It should be to the left of the spine, or at least the left pedicles, and at or above the level of the duodenal bulb. You don't need to see midgut volvulus on an upper GI series to diagnose midgut volvulus. It's presumed, if there is malrotation, that it's intermittently volvulizing, and that's why the child has bilious emesis. But this is a surgical emergency, and this patient will go on to get a LADS procedure. All right. 10-year-old with neck swelling. We've got axial and coronal contrast enhanced CT images of the neck. We'll say right neck swelling. So which of the following congenital lesions is most likely? Dermoid, foregut duplication, branchial cleft cyst, or a thyroglossal duct cyst? And the answer here, of course, is a branchial cleft cyst. So there's different types of branchial cleft cysts. Type 2 is going to be far and away what you're going to be seeing most likely in your practice. This is about 90+% of branchial cleft cysts. The location of this lesion is very typical. Anterior to the sternocleidomastoid muscle, posterior to the submandibular gland, lateral to the carotid sheath. Type 1 branchial cleft cysts, you may see also, it's near the external auditory canal or the parotid gland. Types 3 and 4 generally are rare. We more often suggest it than we see it. Type 4, for example, is associated with left lobe thyroiditis frequently. But other considerations to think about when you have a cervical cystic lesion. Thyroglossal duct cyst is the big one. That's actually the most common cervical cystic lesion, but these are virtually always midline, at or above, or at or around the level of the hyoid bone. Branchial cleft cyst, of course, and then necrotic lymph node would be another mimicker for a cystic lesion. All right, AP pelvis radiograph in a 9-year-old with left hip pain. So what's the most likely diagnosis? Developmental dysplasia, septic arthritis, slip capital femoral epiphysis, or SCFE, or Legg-Calvé-Perthes disease, or just Perthes disease? All right. Diagnosis here is Perthes osteochondrosis. So this is idiopathic necrosis or osteochondrosis of the femoral head. It peaks around 5 or 6 years of age. Boys are going to be more common than girls. On radiographs, you're looking for subchondrolucency. That's that crescent sign, although that's pretty uncommon. That's very early. The flattening and sclerosis is something we see more often in our practice. That usually happens later on in the disease because the child has had pain for a period of time. The treatment is oftentimes non-surgical, so they'll cast or brace these kids, allow the osteochondrosis to heal, and then the femoral head will essentially regenerate. But sometimes these kids can progress to degenerative arthritis and may require surgical osteotomies for therapy. All right, case 14. Prior preterm or 30-week neonate with macrocephaly. We've got sagittal images of the left and right lateral ventricles, as well as a coronal image of lateral ventricles. I don't ask the question, but it's you can see the sulcation pattern looks pretty simplified on that coronal image. So how would this germinal matrix hemorrhage be graded? 1, 2, 3, or 4? And the answer here is grade 3. So germinal matrix hemorrhage, the germinal matrix is a very friable substance. It lives in the walls of the ventricles, essentially. It generally involutes by 35 weeks of age, but it can be, obviously, in kids that are preterm, it'll last postnatally. And because it's friable, it's prone to hemorrhage. So the 4 grades of germinal matrix hemorrhage. Grade 1, it's isolated to the caudothalamic groove. Grade 2 is where you have hemorrhage into the ventricles, so let's say along the choroid plexus, but the ventricles are normal in size. Grade 3 is when you have intraventricular hemorrhage, but now the ventricles have enlarged. And then grade 4, it's not really in the same spectrum, but when you have parenchymal hemorrhage due to venous infarction. So that's the most severe type of germinal matrix hemorrhage. So in this case, if you go back here, we've got some layering hemorrhage along the choroid plexus. On the sagittal images, it looks lumpy bumpy because of layering blood products. And then, of course, the ventricles look large on the coronal image. So the combination of intraventricular hemorrhage with ventriculomegaly puts this as a grade 3. All right. Preterm infant with abdominal distension. We have an AP radiograph. Got a feeding tube in place. So the question here is, what's the most likely postnatal age of this patient? 2 weeks, 6 weeks, 12 weeks, or 24 weeks? Again, this was a previously preterm infant. And the answer here is 2 weeks because the condition here is necrotizing enterocolitis. It's most often in preterm infants in the first month of life. So 1 to 3 weeks old. Abdominal distension and bloody stool are the most common clinical features we see. On radiographs, the most common feature you'll see is fixed bowel distension, which is non-specific, of course. Any type of ileus can produce that. Pneumatosis is going to be the hallmark feature for necrotizing enterocolitis. And for advanced cases, you'll get frank perforations. You'll have pneumoperitoneum, and you might see portal venous gas. And that doesn't necessarily imply that it's bowel necrosis. That can be a transient feature with NEC. The initial treatment for NEC is going to be bowel rest, so nothing by mouth or NPO status, intravenous antibiotics, and we typically get serial abdominal radiographs, usually on a cadence of about every 8 hours or so, until we follow up the pneumatosis if we see it, and we'll follow up the bowel gas pattern. Next case is a 15-year-old with ankle pain. We've got AP and lateral radiographs of the ankle. Looks like they sustained some trauma. And the question here is, which type of Salter-Harris type fracture is this? 1, 2, 3, 4, or 5? The answer here is Salter-Harris type 4. This is a triplane fracture, known colloquially as that. So this is just a brief review of Salter-Harris type fractures. So normal physis, you've got the epiphysis as the secondary ossification center of the long bone, the physis or the growth plate, and the metaphysis adjacent to the physis. So type 1, the classic one we see is slip capital femoral epiphysis, but it's a fracture through the physis. It's not a very common fracture overall. We sometimes raise that concern with the distal fibula. I would say that's the most common site we see, but also the proximal femur with SCFE. Most common overall Salter-Harris fracture by far is the Salter-Harris type 2 fracture, where you have a fracture through the physis and the adjacent metaphysis. Salter-Harris type 3s, the most common type we see is the juvenile Pilot fracture of the distal tibia. Salter-Harris 4 is what I showed you, and that's the most common site, is the triplane fracture. The other common site we see for Salter 4s are going to be in the lateral condyle fracture of the humerus. Salter-Harris 5 is a rare injury. It's a crush injury where you get physeal obliteration. I don't know that I've ever definitively seen a Salter-Harris type 5, at least in my own clinical practice. Okay. 6-month-old with a distended abdomen. We've got axial and coronal contrast enhanced CT images of the liver. Question here: which of the following laboratory markers is most likely abnormal? beta human chorionogonadotropin or beta HCG, alpha fetoprotein, AFP, CA125 or HVA and VMA. The last one is a norepinephrine metabolite. And in this case, it's alpha fetoprotein. This tumor is going to be hepatoblastoma. It's the most common primary tumor of the liver in kids. The majority of these kids are under 5 years of age. Elevated alpha fetoprotein is it's a very important elevated tumor marker specifically for hepatoblastoma. These tumors like invading veins, so they may invade the IVC. Other things to think about: liver tumors in general in kids. Hepatocellular carcinoma do occur in kids, but oftentimes are older kids getting into that adult age group, or kids with predisposing liver disease, of course, so hepatitis. Hemangiomas, a very vascular tumor, so obviously hyper-enhancing on both CT and MR. The fibrolamellar HCC, of course, has the central scar. Mesenchymal hamartoma is a more pediatric liver tumor where you get in infants or young children, and it has a Swiss cheese appearance where you have this enhancing tissue, but surrounded by these non-enhancing large cysts. All right, 10-year-old boy with hip pain. We'll say it is right-sided hip pain. AP and frog leg lateral views of the pelvis. So what structure is primarily involved with this pathology? Is it the acetabulum, the synovium, the physis or growth plate, or the apophysis, or the another secondary ossification center not related to long bone growth is the apophysis. And the answer here is the growth plate. So this is a physeal abnormality. This is SCFE. We talked about it briefly in our salt to hair slide. We see these more common in adolescent overweight boys. These can present oftentimes with hip, groin, or knee pain. Knee pain is going to be the referred pain. I think about SCFE as a Salter-Harris type 1 fracture of the femur. The head generally slips inferiorly and posteriorly, so I think about hip in my mind. But of course, with any fracture, you talk about the fracture with the distal fragment. So the metaphysis actually displaces superiorly and anteriorly with respect to the physis. Frog leg lateral view shows the fracture usually in greater conspicuity. You can also draw Klein's line, a line on the AP radiograph along the outer margin of the femoral neck, and that should intersect the lateral sixth of the capital femoral epiphysis, but on a SCFE, it may not intersect the epiphysis at all. All right, 5-year-old girl with headaches. We've got sagittal post-contrast T1 image on the left panel. We've got an axial T2-weighted image on the bottom middle panel. And then on the right-hand image, we've got a non-contrast sagittal CT image. And the question here is, what's the most likely diagnosis? Germ cell tumor, pituitary adenoma, craniopharyngioma, or astrocytoma? All right, and the answer here is a craniopharyngioma. Another great pediatric brain tumor to know about. Most common cellular or supracellular tumor of childhood. The majority of these have cystic components, and the majority of these have calcification. So a cystic tumor with calcification in this region is going to be craniopharyngioma, really until proven otherwise. Other considerations might include germ cell tumors. Germ cell tumors in kids like around the third ventricle, so they range from the sella to the pineal region and hug the wall to the third ventricle. Astrocytoma, obviously, that's a common tumor in general, both in kids as well as in adults. And pituitary adenoma, this is more of an adult diagnosis. You can see these in kids, although it's relatively uncommon. All right, 15-year-old boy, history withheld here. We've got AP and lateral chest radiographs, as well as an axial CT image. Question here, what's the most common clinical presentation for this kid? So how did this adolescent present to us? Chest pain, restrictive pulmonary function tests, reduced ejection fraction on echocardiography, or cosmetic deformity? Now, all of these are theoretically possible, but the far and away the most common is going to be cosmesis. So So this is pectus excavatum. You have posterior depression of the sternum and the anterior inferior ribs. So on chest radiographs, this is a common boards question. Right heart it mimics pneumonia because you have the silhouetting of the right heart margin. Clinically, these patients most commonly present to pediatric practices for cosmetic, because in adolescence they become self-conscious because of their chest depression. You can have exercise intolerance and you can have dyspnea. These are reported symptoms. The Haller index is what we most frequently look at on an axial CT image. So we get the transverse diameter of the chest divided by the anteroposterior diameter or caliber of the chest. And the index we read about at least is 3.2, and these typically require surgery. Usually these are not of diagnostic dilemma. So virtually all of the Haller indices we measure on CT are going to be abnormal because they self-select to have CT. If you were to use it as a screening study, of course, you're looking for a Haller index greater than 3.2, but we oftentimes look at 5, 6, et cetera. So this is not a diagnostic dilemma at that point. The treatment can vary depending on the institution. A common treatment is a placing of a substernal bar, and you lift the sternum anteriorly. The Nuss bar is the eponym associated with the bar. The postoperative finding to look for any type of repair for pectus excavatum is for pneumothorax. And that's true both with when you place the bar as well as when you remove the bar. All right, 1-month-old boy with non-bilious emesis. We've got an ultrasound image here. So what's going to be the treatment of choice for the condition I'm showing you in ultrasound? Is it a pyloromyotomy, intravenous antibiotics, the LAD procedure, or a gastropexy? And this treatment is pyloromyotomy. So on the condition I'm showing here is HPS, or hypertrophic pyloric stenosis. This one also has a strong male predilection. Pretty infrequently, anecdotally, I don't see this very common in female infants. Projectile non-bilious emesis is the classic clinical indication. This is what we get all the time out of the emergency department looking for HPS. Ultrasound is going to be your preferred study. You see elongation of the pyloric channel, and you also see mural thickening, both single wall as well as double wall. And over the course of, let's say, a 10-minute examination, there's usually either no or minimal passage of gastric contents through the pylorus. The way I remember this is pi. So I think about a single wall thickness of normal is going to be less than 3 millimeters. So abnormal is greater than 3 millimeters or greater. And then the channel length is going to be normally less than about 14 millimeters. So the length of the pylorus. So greater than 14 or 15 at least, or greater, is going to be suggestive of hypertrophic pyloric stenosis. And this treatment is surgical. So they make a longitudinal incision of the pyloric musculature. All right, case 22, 18-month-old boy with weight loss. We've got an AP chest radiograph and an image of the AP radiograph of the knee, or one of the knees. So what's the most likely diagnosis? Leukemia, skeletal dysplasia, osteogenesis imperfecta, or rickets? And the correct response here is rickets. So this is where we get deficient calcification of osteotic matrix. So the matrix for bone formation gets laid down properly, but you don't calcify it normally. Vitamin D deficiency, this is what we see most commonly in the United States. We typically see these with nutritional deficiency. So we might see these with cases of abuse in infants, and we also might see these in kids with very picky diets where they don't get enough vitamin D. You get widening of the zone of provisional calcification, and this is part of the physis, essentially, or adjacent to the physis. And now you get cartilage growth without ossification. So on radiographs, what you're looking for is a widened physis. On imaging, you're looking for, in addition to a widened physis, you get an irregular appearance with the metaphysis. So you get this frayed appearance with it, which is what I had shown you with on the knee. It can also look cupped. So the central part of the metaphysis is even more deficient. So it almost as though it looks like a V, like a seagull. The rachitic rosary is basically expansion of the costochondral junctions on a radiograph. So it looks like bulbous ends to the anterior ribs on a chest radiograph. And of course, you're going to get generalized demineralization. So other conditions you might look for, leukemia gives you loosened metaphyseal bands and can give you demineralization as well. And there's obviously over 1,000, I think, skeletal dysplasias of which to choose from. So it's not really a diagnosis per se, but a category of diseases to think about. All right, 11-year-old girl with abdominal pain. We've got ultrasound images, midline transverse images in the region of the pancreas, as well as axial and coronal contrast enhanced CT images. Again, I'll direct your attention to the pancreas. And the question here is, what's the most likely diagnosis for this mass? Is it pancreatoblastoma, solid pseudopapillary tumor, or SPEN tumor, islet cell tumor, or adenocarcinoma? I probably wouldn't ask you ductal adenocarcinoma because that's obviously the most common adult pancreatic tumor, and the diagnosis here is going to be solid pseudopapillary tumor. Common pancreatic tumor in children, we see these very frequently in young women, so second and third decades of life, has very low grade malignant potential, thankfully, unlike ductal adenocarcinoma in adults. The treatment for these are going to be surgical resection. So usually the surgeon just shells these out, and these have good prognoses. It does not have a tendency to metastasize. Other things to think about when you have a hypodense lesion in the pancreas on a contrast enhanced study, an acute fluid collection. So certainly if a child has pancreatitis, but children do get pancreatitis. In the more non-acute setting, you might think about a pancreatic pseudocyst. So it's had several weeks to form. Pancreatoblastoma, it's an immature cell type, rare tumor within the pancreas. And then islet cell tumors do occur in kids, although it is uncommon, and they can be endocrinologically active too. Okay, 4-month-old girl with cheek swelling, case number 24. We've got a image of the right cheek with and without Doppler, with or without color Doppler. So what's the most appropriate initial management for this lesion? Steroids, propranolol, embolization, or observation? So the correct response here is going to be observation. So this, of course, is an infantile hemangioma, has a characteristic 2-stage life cycle where it initially grows and proliferates during the first few months, and then it regresses or involutes beyond that. On ultrasound, you're looking for a vascular mass. So it's a vascular anomaly as an umbrella category, and then you have vascular mass as well as vascular malformations. When you have a mass, think about a vascular tumor, of which infantile hemangiomas are far and away the most common type of vascular masses. MR will depend on stage in terms of what it looks like. It usually has a lobular margins of the mass, high light bulb bright T2-weighted signal is a buzzword. You frequently see flow voids in and around the lesion, intense enhancement early, because it's obviously a very vascular tumor, and that enhancement will fade as the tumor involutes. Main consideration, of course, is a vascular malformation. It typically does not have a mass. A small venous malformation can oftentimes mimic an infantile hemangioma, especially in infancy. If you have a 5-year-old with what looks like a vascular lesion, it oftentimes isn't an infantile hemangioma because that's the wrong age. Can it be a non-involuting congenital hemangioma? It can be, but these are not common tumors. Those, by the way, are not GLUT1 positive like infantile hemangiomas are. And if you have a mass that it's moderately vascular or perhaps avascular in an older child out of infancy, it doesn't have to be a hemangioma. So that's when you start worrying about a soft tissue sarcoma. Treatment for infantile hemangiomas, usually these resolve on their own. So observation is going to be the most common therapy. For infantile hemangiomas that don't resolve or are large, you can give propranolol as well. That's actually replaced steroids in most places for treatment of infantile hemangiomas. Okay. 15-year-old with abdominal pain. We've got multiple images from an MR enterography. So I'll direct your attention to the bowel, essentially. We've got a coronal and axial T2-weighted images on the top panels, and then coronal and axial T2-weighted fat-suppressed post-contrast images. on the bottom panels. All right, and the condition, where is this condition that I'm depicting most commonly located? Distal esophagus, at the junction of the duodenum and jejunum, the terminal ileum, or the splenic flexure. And the correct response here is the terminal ileum. This condition, of course, is Crohn's disease, where you have transmural inflammation of bowel. Most common location is going to be the terminal ileum. In theory, anywhere from the mouth to the anus can be affected with Crohn's disease. Kids, compared with adults, have more common colonic involvement. On the bowel, with bowel, you're looking for mural thickening, enhancement. You may see diffusion restriction within the wall of the bowel. These can show strictures as well as upstream dilatation of the bowel, upstream of the strictures. In the mesentery, you can also look for inflammation, or it looks like really edematous mesentery, looking for lymphadenopathy, as well as this creeping fat appearance. So you get this basically increased fat within the mesentery. Because it's transmural inflammation, you get extraintestinal manifestations of Crohn's disease. So you're looking for inner loop abscesses, phlegmons, fistulas. The fistulas can be perianal fistulas. So actually perianal fistulas is a very common reason for why we image kids. They first time present as a teenager with perianal fistulas, and then they eventually get diagnosed with Crohn's disease. All right, case 26, 2-year-old boy with vision loss. We'll say left-sided vision loss. We have an axial T2 weighted image. In the left panel, the middle panel is an ADC map from a diffusion weighted sequence, and then on the right panel is a susceptibility weighted image, or a gradient recalled echo. So what is the clinical feature most commonly associated with this type of condition? Is it leukocoria, amaurosis fugax, orbital cellulitis, or opsoclonus myoclonus? And the correct response here is leukocoria, the white pupillary reflex. So retinoblastoma is the condition I'm showing you. This is the most common intraocular or within the globe tumor of childhood. On clinical examination, these patients present with white pupillary reflex. So the clinician will shine a light into their pupils. In theory, that should produce a red reflex, but in these cases, it shows up as it looks white to the ophthalmologist. On imaging, it's essentially a calcified intraocular mass virtually all of the time. Most of these cases are going to be sporadic. You can have familial forms, these are autosomal dominant. There's genetic abnormalities not specifically on chromosome 13, and these are also prone to get sarcoma and melanoma. Familial cases, you do have a high proportion of bilateral retinoblastomas, and you're also looking for the non-ocular tumors, so the pineoblastomas, and let's say the germ cell or the PNETs that are occurring in the cella, oftentimes around the third ventricle. MR is typically done for staging, and this may involve the optic nerve, the orbit, and you can have intracranial leptomeningeal metastases as well. All right, case 27, 15-year-old boy with dyspnea. We've got a chest radiograph, and then sagittal and axial contrast enhanced CT images of the chest. We have some nice example for the trainees, mediastinal widening on the AP radiograph there. Question, what's the most likely diagnosis? Neuroblastoma, lymphoma, thymoma, or germ cell tumor? And this diagnosis is going to be lymphoma until proven otherwise. So differential considerations for mediastinal masses in kids. For anterior mediastinal masses, a normal thymus mimics a mass very commonly. We see this all the time, almost on a, I would say, weekly basis. The normal thymus is very large in a child under 5 years of age. You can see lymphoma involving the anterior mediastinum as well. Generally, these are older kids where the thymus is starting to involute at this point. And you can have germ cell tumors as well in the anterior mediastinum. Middle mediastinal masses, lymphadenopathy really of any cause, lymphoma being a very common cause, but certainly other types of infections can give you lymphadenopathy. And you can get a foregut duplication cyst in the middle mediastinum. These are oftentimes in the central chest, so the middle mediastinum as well as the middle third of the lung parenchyma. And then a posterior mediastinal mass, you should be thinking about neuroblastoma in a child as the diagnosis to prove. All right, case 28, 5-year-old girl with dysphagia. So we've got AP and lateral images from a fluoroscopic esophagram. So what's the most likely etiology for this esophageal narrowing? Is it a foregut duplication cyst, eosinophilic esophagitis, right arch with an aberrant left subclavian, or an esophageal web? And the answer here is a right arch with an aberrant left. Here's the contrast-enhanced CT image axially showing the right arch with the aberrant left, fairly sizable there with a small diverticulum of Commerell at the origin of the subclavian. So with the right arch, the aortic arch courses over the right main bronchus. This can cause a right tracheal indentation on the chest x-ray. For those trainees out there, I definitely encourage trainees to look at the trachea, the airway most commonly on pediatric radiographs, more so than in adults, I think. On fluoroscopy, that posterior indentation of the upper esophagus, I'm always looking for that when I'm doing my lateral esophagams. You look for an oblique indentation on the frontal. Usually it's a corroboratory finding. Usually the finding is generally made on the lateral. The majority of these patients have a dilatation of the origin of the subclavian. We mentioned the diverticulum of Commerell. A vascular ring can be formed. So this is where you have a ligamentum arteriosum connecting to the left subclavian or diverticulum. So between the right arch and the ligamentum arteriosum, you can create a vascular ring or constriction of the esophagus and the trachea. And these patients, it's this dysphagia lusoria is that classic clinical finding, although I can't say in real life that I've ever really seen that. That is what you read about though. Stridor and dysphagia are more common findings. All right, case 29, 2-year-old boy with abdominal pain. Got axial and coronal contrast-enhanced CT images, and then a planar images from a nuclear medicine study. I'll hold information on the radionuclide. So what cell type does this tumor arise from? Is it neural crest cells, skeletal muscle precursor cells, transitional epithelium, or nephrogenic rests? And the correct response is going to be neural crest cells. This is neuroblastoma, a very important tumor to know in pediatric patients. You have a malignancy of neural crest cells forming the neural crest cells are what forms the sympathetic chain ganglia. Most common locations, the adrenal gland, the retroperitoneum, so outside of the adrenal gland, but within the retroperitoneum, and then finally the posterior mediastinum. Those 3 locations comprise more than 90% of neuroblastomas. You have this really infiltrative, insinuating mass. It tends to encase vessels. So we talked about displacing vessels with Wilms tumor. Encasing vessels is typical of neuroblastoma. It can also displace the aorta off the spine. That sounds reminiscent of lymphoma, especially in adults. Calcification is very common with neuroblastoma as opposed to Wilms tumor. And then finally, the radionuclide I was trying to key you into is I-123 MIBG. We typically stage kids with neuroblastoma with this radionuclide, although certainly PET-CT is going to be a good one as well, especially for poorly differentiated tumors where I-123 is not going to be sensitive for these specifically aggressive neuroblastomas. All right, my last case, I think it's 12 o'clock, so I'll be quick as I can. 9-year-old girl with arm pain. AP radiograph of the shoulder. So what imaging sign is depicted here? Rings and arcs, double line, drooping lily, or fallen fragment? So the sign here is the fallen fragment sign. The diagnosis is a solitary bone cyst. The proximal humerus is about half of cases. The femur is another common site. So basically long bone, sites of long bone growth. It's the most common cause of a pathologic fracture in a child. It's usually a benign appearance. So it's lucent lesion, thin sclerotic margin, so a non-aggressive lesion. The fallen fragment is showing the pathologic fracture fragments layering dependently within the cyst fluid. And treatment's oftentimes surgical. So the orthopod will go in to do curettage with bone grafting. Rings and arcs calcification. This is a buzzword for chondroid matrix calcification. Enchondroma is the most common lesion we see, it's a benign bone lesion of cartilaginous tumor, hands and feet. Double line sign is an MR sign, and this is typically associated with osteonecrosis. And then finally, drooping lily, this is the VCG appearance of reflux into a lower pole moiety of a duplicated collecting system. So those are, again, particularly for the trainees out there. Thank you all so much for your time.
Thank you very much, Dr. Iyer. That was a very nice presentation, very nice way to review the cases we frequently encounter in our pediatric imaging practice. Are there any questions from the floor you'd like to address? Actually, I have one question that's a personal one, if you allow me to.
Sure.
Yeah. Are you familiar with, the neuroblastoma, congenital neuroblastoma, neuroblastoma S, the one we see in the neonates? Are you familiar with cases that the primary was not from the suprarenal glands, like when extraadrenal congenital neuroblastoma? We've seen cases like this.
They're not common, but we do see them. I've seen some cervical congenital neuroblastomas, and we've seen extraadrenal retroperitoneal neuroblastomas, but they're not very common.
Actually, if you may, can I show some images I've seen in a case a couple of weeks ago, but unfortunately it was lost in. I didn't follow up the case because I think it was referred to a specialized pediatric cancer center. So this is the case I was talking about. This was a full-term neonate, and I was doing this screening abdominal ultrasound, and I found these vascular liver mets. Okay, and I think they are very obvious here. And then there was this hypervascular mass in the pancreas. Okay, and then I found this other retroperitoneal mass just in front of the aorta. So it was quite confusing. My final report was I suggested that's an extraadrenal neuroblastoma, but could it be a blastoma also? Because you can see here the both suprarenals are clear. So what's your opinion about this case? I'm just sharing it for like some brainstorming and sharing experience in cases we see.
Yeah, it's interesting. I mean, it's not, I don't know that. I guess ultimately, I'm not sure what the diagnosis is going to be.
Yeah, I would blame for that. I just what would you do if you're in my shoes? Because sometimes we encounter such challenging cases. What do you think the ideal report should be?
One thing I would say that this seems unlikely for neuroblastoma is almost always neuroblastoma is very hypovascular rather than hypervascular. Those look pretty hypervascular on ultrasound, especially in the liver. But usually these are hypovascular tumors. Typically, a neuroblastoma doesn't enhance as much, and it's typically not as avid on color Doppler interrogation. So that's a little unusual for neuroblastoma. I guess in terms of what else could it be? Could it be? Is that extra? I mean, I guess what parenchyma is that? Is that in the liver still?
This was in the region of the pancreatic body, and I think this was related to the pancreatic head. This mass was related to the pancreatic head, and I heard also this retroperitoneal structure here. It was in front of the aorta. It was about at the level of L3, L4, something like that. This solid calcified mass. It had this calcification also within. I know this is not a complete study to show, and actually the baby was referred to a specialized cancer center. I tried to follow up through some colleagues there, but I didn't get the final diagnosis yet. I was just sharing it as an interesting case that sometimes every now and then you get a challenging case like this.
Yeah, no, I think that's true. I think I've seen hemangiomatosis. If you were to just be the liver finding, I've seen many cases of hemangiomatosis.
Yeah.
Where you have, but I since now you have extrahepatic lesions. How old was the child?
The child was about, I think, 1 week or something. He was a full-term 1 week baby or something. Yeah.
I mean, I don't think metastatic congenital neuroblastoma is a bad thought. I just think it's a little unusual. I mean, it's unusual in a lot of different ways, but the vascularity within the tumor is unusual to me.
Well, thank you very much. I was just sharing it. It's nice to have another set of eyes to look on these interesting cases.
Oh, sure, absolutely.
Thank you very much. Again, thank you very much for your time, and it's an honor to have you with us, and it was a great pleasure to have you with this very nice review. I hope we'll see you again, and I invite you to visit us in person here in Egypt.
That would be great. I would love to do that. Thank you so much, and I appreciate the invitation today, but hopefully that'll be in person someday. I agree with you.
Yeah,
that'd be nice.
Thank you.
Thank you, everyone.
Thank you so much, Dr. Ramesh. Thank you, Dr. Muhammad Toumi. Thank you, Islam. We'll meet again next Friday, inshallah. Assalamu alaikum wa rahmatullah.
Assalamu alaikum. Shukran to Islam.
Alaikum salam. Shukran, Dr. Muhammad. Shukran jazakallah.